All right. Everyone can see my screen still. Everyone can hear me and see me.
Yes.
Excellent. That's always a good start. Just get some stuff all set up. All right, as you guys can see, what we're going to be talking about tonight is respiratory and cardiac emergencies. So this is going to be covering quite a few different topics. We're going to be talking about plenty of different conditions, all with different implications for us. But really what can be said about this topic is it's essentially the bread and butter of EMS. We're going to be going to a lot of calls revolving around respiratory and cardiac emergencies. And it's probably some of the more involved calls that we'll have, calls that we can actually assess for and treat different conditions. And this is kind of where we're going to be playing a lot. There are a lot of populations that suffer from respiratory and cardiac emergencies. And a lot of times they are the populations that are calling the 911, calling an ambulance most. So we are going to see these quite a bit. So this is good information for us to go over. Starting with my human home, these people are going to have issues with their central air system. They're going to have issues with their vents, their pipes, and their pump. This is kind of what we're going to be talking about. Respiratory and cardiac emergencies tend to go pretty well together. Our respiratory system drives our oxygen to be sent out through our body, which is connected to our heart, right? They all kind of play into the same thing. So a lot of times we'll see cardiac issues kind of overlapping with respiratory, and then vice versa. We're going to see respiratory overlapping with cardiac. So having good assessment here is going to make a big difference. So we're going to actually jump right in, and I have a question for you. So you guys are dispatched to a local residence for a 70-year-old who's complaining of difficulty breathing. What are the first steps of our assessment here?
ABCs.
Wrong. You got shot.
BSI seems safe.
Yeah. Always seen safety BSI. It's always a trick question. If I ever ask you what comes first on a scenario, it's always seen safety BSI. Give me a little jazz hand. Show me I got the gloves, essentially. But you're not wrong, right? After doing our scene size up and our general impression, determining what the severity of our patient is just by looking at them, you're absolutely right. ABCs, we're going to go over, do they have any life threats? Is there an airway issue? Is there a breathing issue? Or is there a circulatory issue? But always is first, making sure the scene is safe, and then getting our eyes on the patient. Okay, from what our eyes tell us, what do we think is wrong? So what might we expect a 70-year-old with difficulty breathing to look like, to present as?
In the triangle position, potentially?
Yep, they might be in that tripod position. They might be leaning forward, kind of resting their knees on, or their hands on their knees, trying to get some extra help with gravity and some pressure. Sure. What else?
They might be anxious or distressed.
Yeah, absolutely. If they're having difficulty breathing, they're likely going to be anxious, and might be upset. They might be distressed just in general. Absolutely.
Disoriented.
Potentially, yeah. Along with not breathing very well could mean that they don't have enough oxygen. Therefore, they might be a little bit confused. Absolutely. Great stuff. What might we expect to see based off of like their skin color and their disposition? Would they be flushed? Would they be pale? Would they be cool? Would they be hot?
I think they'd be pale, cool, cyanotic, maybe.
Yeah, if they're truly having some really bad difficulty breathing, you can look for that blueness around their lips, pallor, just general paleness. Sometimes, depending on what it is, though, they might be flushed and red. So this is going to lead into our next thing. So next comes our primary assessment. So we're going to ask them, we're going to gain their level of responsiveness, whether or not they can look at us, whether or not they're unresponsive, whether they're altered, whether they're conscious. Then we'll do those ABCs, and we'll get their chief complaint if they're alert and talking to us. So they say, I've been having difficulty breathing for the past 30 minutes. It's really bad. Their airway's open, their pulse feels strong, but they're breathing really bad. What do you want to do next? What are your next levels of assessment?
Listen to their lungs, blood pressure, SpO2, heart rate.
Yep, so vital signs, right? Let's get a baseline set. Let's listen to their lungs, especially if they're having difficulty breathing. Now, what is you guys as basic EMTs? What can you listen for in lungs for an assessment?
Wheezing or whispery.
Can you?
You can hear.
Not within our scope.
No. So that's the tricky part is you guys listening to lung sounds with a stethoscope, you are only able to listen for and determine presence and equality. So essentially what you guys can do is listen to the lungs and say, okay, when they take a deep breath in, I hear air going in up here and down here, right? I can tell that it's symmetrical. Even if you are able to determine that person is wheezing by listening with your stethoscope, if you declare that they are wheezing based off of what you hear with your stethoscope, that's actually out of your scope of practice. It's out of your stethoscope of practice. But what you can do is if they are wheezing, right, they're obviously wheezing and you can hear it without your stethoscope, you can declare they are audibly wheezing. There are plenty of types of wheezing where you can't hear it unless you listen with a stethoscope. And so that's what you aren't allowed to determine. But if someone's sitting there wheezing, you can say, hey, that person's wheezing. I heard it with my ears. So yeah, absolutely. Let's check to see if they're wheezing. Let's get their SpO2. Let's get their vital signs. What might be some of the first treatment that you're thinking of?
Oxygen.
Yeah, absolutely, right? If their SpO2 is low, if they're having distress, if they're cyanotic, give them oxygen. That's definitely going to help. Yeah, great. So we're going to do our history. We're going to do a physical assessment. We're going to do our vital signs. And then essentially we're going to transport them if they want to. And we should always, you know, if they call 911 and they want to go to the hospital, we should always recommend that, especially if they're having difficulty breathing. But in our transport, we're going to reassess their primary assessment. So we're going to redo our ABCs. We're going to recheck their mental status, see how their chief complaint is doing, check their vital signs, and then see if what we've done has helped, right? So if we've given them oxygen 5-10 minutes later, we want to see if their SpO2 hasn't increased, or we want to say, hey, has your difficulty breathing gotten any better?
At what point would you give them aspirin?
For difficulty breathing?
Oh, I'm sorry. I thought this was coronary related.
Nope. So if it's just difficulty breathing, we don't have to worry about it. But if they're saying I'm having chest pain and we can determine that it's cardiac related, as soon as we learn that and as soon as we determine that we think aspirin would help, we can give it to them.
At what point would we, if they use an inhaler, at what point during this process do we then suggest that we can assist them in using their inhaler?
Absolutely. So we would probably find that out after our secondary assessment, right? We ask them, hey, do you take any medications? Do you have any allergies? That kind of stuff. So after they've given us that, after we've taken a set of vital signs, they say, yeah, I'm having difficulty breathing. I'm prescribed this inhaler, and you can hear that audible wheezing. After you take a set of vital signs, you've given them some oxygen. Yeah, hey, let's help you out with that inhaler. Yep. Great job, guys. So let's take the same thing. What changes, if anything, if it was an 18-year-old that you got called for difficulty breathing? What are you going to think this time?
About their
I would
respiratory.
wonder if they were having some kind of an allergic reaction.
Okay. Why?
Probably the age difference.
What they might have been doing before they had trouble breathing, like a sporting event or something.
Sure. Right. So you kind of exemplified it for me right there is what causes that difficulty breathing will likely be different, right? Somebody who's 70 and having difficulty breathing, we can think, oh, you know, it could be an allergic reaction, but it's more along the lines of a condition, right? COPD, emphysema, something like that. Whereas an 18-year-old, unless they've been smoking since they're 2 years old, right, they probably wouldn't have a condition like that. So the chances of it being something along the lines of a disease like COPD or emphysema, it's much lower. So likely for 18-year-olds, we're thinking allergic reactions or asthma attacks, right? If they were playing sports or doing something like that before. So yeah, absolutely. Great call. That's pretty much it with this one. So don't think too far into it. So the first one we're going to do here is dyspnea. And we're just going to do a bit of review of the respiratory system and some of the same, just intro to respiratory stuff that we've done. But dyspnea is our overarching word for difficulty breathing. So that is just the combination of that prefix difficult, and then pnea meaning breathing. And so this can be caused by a whole bunch of different things, and it can mean a whole bunch of different things. But essentially, some other facts to keep in mind about respiratory emergencies is that this is quite a bit of the amount of people who die every year is around 200,000 people in America die from respiratory emergencies. So not necessarily just diseases, but emergencies related to those. Some of these factors can be intrinsic factors, so things that people cannot control. So being born with a genetic predisposition or a disease that could affect their respiratory or circulatory systems. And then extrinsic factors can be something like smoking, which is a pretty common one, environmental issues, things that cause damage of the respiratory drives and systems. This is the respiratory system. Again, we play a lot in the upper airway with our airways and our masks and our breathing. And then what we get our medications, or what our medications are attempting to do, is affect the lower airway, those lungs, the bronchi, and the alveoli. So those medications, like we talked about in pharmacology, right, that albuterol is designed to open up the bronchi. So those are really the parts that we're trying to affect with that medication. When they constrict, they cause that wheezing sound, they cause difficulty breathing. So we can give albuterol to hopefully open them up and make more clear passageways for that air to get through. Down to the alveoli, which are those ovular sacs at the base of our bronchi. These are where that oxygen actually gets pulled into the blood and gets transferred around. So if there is something wrong with these, if there's something blocking them, that is going to lead to a lot of negative outcomes for our patient. So they can get damaged, right? If you can see, this is a pretty good image of them. So when somebody smokes a whole bunch, right, what they're doing is potentially damaging these alveoli. And especially when you do it over a long period of time and you're coughing a whole bunch and you're causing pressure and all that kind of stuff, what these can do is they can rupture. And so they actually start to kind of lose their surface area and they lose their sponginess. So after a while, they start not reopening when you breathe out. They stop inflating as easily. This is another quick review. So the control of our breathing system is in our brain stem within our cervical spine. When the breathing rate increases, the breathing rate increases if the carbon dioxide level is too high. And then what we can sometimes see in patients who have COPD is that it reverses, is that the oxygen level in their brainstem causes them to breathe. And so if we were to give them too much oxygen, the theory is that they could stop breathing. This does happen, but again, it's very rare. We should not worry about giving too much oxygen to our patients, especially if we think they need it. So some of the potential causes of difficulty breathing, many of the things that we're going to see, the two biggest ones really are going to be damaged alveoli and damaged bronchi. So damaged alveoli is kind of indicative of the disease emphysema, which we're going to talk about. That's when those alveoli have lost some of their shape. They don't rebound as easily. They lose surface area. They get sticky. And then if air passageways are obstructed, that's when we're going to see like chronic bronchitis, when there's just an abnormal amount of mucus being lodged in those passageways. So somebody always has a little bit of a blockage going on in their lungs. Other things that we're going to see is that the blood flow to the lungs is obstructed. So something like a pulmonary embolism, where if the blood flow is obstructed to a section of the lung, that section of the lung is not going to get the blood and the oxygen that it needs. So not necessarily that it needs, it's that when the blood can't get there, it can't diffuse the oxygen into the blood, so the rest of the body doesn't get it. Something else that could happen is that the pleural space is filled. So that pleura is a very thin membrane that covers the lungs, keeps them airtight. And if for some reason there's an infection or an injury, it could either fill with air, called a pneumothorax, or with blood, called a hemothorax. So that's going to cause pressure and make the lungs not be able to expand as much as they could. And a lot of times that goes along with a traumatic injury. So a chest injury that could lead to lung damage, essentially. So whether it's a flailed chest, which is a bunch of broken bones, or if it's a penetrating wound that allows air into the chest cavity. Signs and symptoms of difficulty breathing or dyspnea. Obviously, the first one is they're going to be struggling to breathe. They're going to have that difficulty breathing. You're never really going to look at somebody and be like, are you having difficulty breathing? I can't tell, right? Somebody who's truly having difficulty breathing, you will be able to tell. They will tell you immediately. It's not really something somebody can ignore. So shortness of breath and difficulty breathing, we want to talk about those a little bit because there is a difference. Difficulty breathing is when someone is having physical challenges breathing. So whether or not that's an obstruction, an injury, or something going on with the lungs, whereas shortness of breath is more of a feeling. Somebody feels like they can't get air in, or it's not difficult for them to breathe, but when they breathe, they don't feel like it's doing as much as it normally does. So difficulty breathing, that is what we tend to see more so in respiratory emergencies, whereas shortness of breath is going to be something that's more so reported by people maybe having cardiac emergencies, right? It's not that they're having difficulty breathing. It just feels like they're not getting enough out of each breath. Whereas somebody who's having difficulty breathing, it's going to be a challenge. It's going to be a physical thing. Lacking oxygen is just going to make anybody anxious or restless. They're going to be heightened level of state. They're going to be having a fight or flight response. On severe patients, we're going to see really abnormal breathing rates. So they could be breathing really, really fast and then have periods of apnea in between these periods of tachypnea. We could see them just breathing really fast and really deep at an abnormal level that just would make you feel like you're going to pass out if you tried to do it on your own. And it can range in a whole bunch of different ways. Essentially, the main thing that we're going to look for is just the rate, and the quality. Cyanosis, just showing that there's a lack of oxygen in the blood. They're going to get blue around their lips, in their fingertips. You might even see it in their gums. Abnormal breath sounds, so squeaking, wheezing, things that just sound like they're breathing through water, harsh coughs, anything along those lines. Accessory muscle use, that's a really bad sign. Tells us that they are in severe respiratory distress. So it's when those muscles on the inside of our ribs are working extra hard. Tripod position, they're going to have that sympathetic nervous system response. So they're going to be amped and they might cough. So right off the bat here, just tell me what you guys think of this. So you're called to a sick child. You find a 4-year-old female sitting very still on the edge of her bed, quiet, and she's breathing fast. Her symptoms started about 4 hours ago with a sore throat. She's now feverish, has a fever, and is refusing to eat or drink. She can't talk, but will nod her head, and she is drooling. Her pulse is 140, respirate is 40, her blood pressure is 90/60, and her skin is very warm. Here is a little cheat sheet for you guys. Right off the bat, what do you think? Sick, not sick?
Sick.
Yeah, why?
Because she has a sore throat and she's feverish and
Okay,
drooling.
yeah, that's actually great. So in EMS, when I say sick or not sick, I mean, are they going to die? Do they need the hospital, or can we hang around a little bit? So yeah, I'd say that she's probably sick. But for us, it's like, okay, is she severe or not so severe? What do you think? Do we need to get her to the hospital emergently, or could we stay and play?
Yeah, the
She's
fact that
in
she
the
can't
hospital.
talk and her respiratory rate is 40 breaths per minute are both signs that you need help.
Okay, yeah, absolutely. So something is going on with her airway and breathing. She's having difficulty breathing. What do we think our first assessments are going to be? What are we most concerned with here?
The
She could have
breathing.
she could have dehydration from the fever.
Okay. Started about 4 hours ago and she's now feverish. That would be a really quick time for
Oh,
someone
sorry.
to be dehydrated. Nope, you don't have to apologize. That's a good thought, right? That's something we should consider. But usually that's, if she's having difficulty breathing, that's not going to be the same. It's not going to be the emergent thing for us to consider. Somebody in the chat says allergy. Yeah, absolutely. That could be like a delayed allergic reaction. But we wouldn't know for sure. What else are you guys thinking?
Her respirations are high. So, wait.
Yep, they're a bit high.
Blood pressure. And her
I know
heart rate.
in kids, the respiration rate when they have a fever kind of rises a bit. It's just they're trying to cool their body.
Yeah. Is this, do we think that this is from the fever?
No.
It sounds like she has an obstruction somewhere because she's drooling, so she's unable to swallow as well, it sounds like. So it's probably a combination.
Yeah, absolutely. So I'd say that this patient, very severe, her life is in danger. We should get her to the hospital immediately. This is pretty textbook epiglottitis, in which we'll talk about that. right about now. So she is having an upper airway obstruction, which these three things, so a physical obstruction, croup, and epiglottitis, these are the big ones, especially for kids. We are going to listen to some breath sounds here. So you guys hear that okay? Can you hear it at all?
It's a little quiet.
Airway obstruction.
Does that help?
Two of the most common respiratory problems that children can present.
It's all the way up.
With our upper and lower airway obstruction.
Is that any better at all?
Now, there's
Yeah, that's good.
set of conditions that can result in upper airway obstruction, but what they all have in common is typically some edema of the soft tissues of the upper airway, either in the subglottic region, below the vocal cords, or in the soft tissues above that, such as the epiglottis or hypopharynx. When you have obstruction in the upper airway, you'll demonstrate increased work of breathing because you're trying to use your muscles to draw in air against a higher resistance than normal, remembering that the pediatric airway is already fairly small in caliber. With upper airway obstruction, you'll typically see suprasternal retractions or potentially sternal retractions as well in a young infant with a compliant sternum. And there's a characteristic noise that may accompany this called stridor. And stridor is a high-pitched noise that occurs on inspiration and is the noise essentially of the turbulent airflow that the infant is generating by drawing air in through a narrowed area. If the infant has obstruction at a higher level, for instance, swelling of the tongue or excessive secretions or poor muscle tone resulting in hypopharyngeal obstruction, the sounds that may be produced are much coarser, sounds that are called stertor, for instance, which sounds more like a snoring or a rattling type of respiration. This can be easily distinguished from stridor if the baby responds to a jaw thrust maneuver, where when you relieve the upper airway obstruction from soft tissue, the noise improves. Subglottic edema won't have
So the main conditions or the sounds we're looking for there, what we're going to see a bit is stridor. So that kind of high-pitched squeaking, and then also snoring. Those are some of the more common upper airway obstructions that we're going to see. They are also pretty common when we talk about croup and epiglottitis, because they are upper airway obstructions. It's going to present those type of sounds. Okay, lady, thank you. So here is a little bit more clear sound of stridor in an infant. So you can hear that it sounds like it's up higher in the airway. You can kind of tell from where you hear that sound on the inspiration and expiration. So that kid was definitely struggling to breathe, and it sounds like there is something higher up in the airway, not necessarily lower down. So croup is the first condition we're going to talk about because, yeah.
But just real quick, will stridor sound the same in an adult as that example, or does it have like a deeper quality?
It'll definitely have a deeper quality. You can hear like the infant in that. If you had an adult doing that, it'll sound similar, as in it'll be a similar sound. You can tell that it's higher up in the airway. It's going to be a little bit more squeaky, but because adults just have bigger anatomy, you're going to get lower sounds. So we're going to first talk about croup, because good news is this one is pretty survivable. Very few children die from this. However, it is a pretty scary thing to go through. I was actually recently with my dad and my mom, and they were telling me about when I had croup as a kid, and they were panicking because it sounds and looks and it's very scary. However, it's usually pretty survivable, but we don't want to play around with it, because my bold here is that epiglottitis and croup can often be mistaken for one another. There are ways to tell, but pretty much how we want to like approach every condition, is that we have a baseline set of knowledge. We're not doctors. We can't be the ones to say it's not this versus not that. So if a kid's really having difficulty breathing and we're not sure, don't play around with it. Get them to the hospital, get them what they need. So what this is it's a viral infection, and that's going to be pretty important. It's a virus that affects the upper airway. So it's going to cause inflammation of the pharynx, the larynx, and the trachea. So kind of in the throat up into the area where we can put our airways, the pharynx, right? What it will cause is this kind of bark-like cough. So somebody has a very prominent cough. They call it like a seal, right? Like a seal barking. It kind of sounds like that. And this usually targets or usually affects the younger population. So 6 months to 3 years. However, it is possible for an adult to get croup, but it's very rare. The most you're going to be able to do for somebody with croup is if they have a low SpO2, get them oxygen. Body positioning is really good, having them sit up. But in general, kids who are in distress are really tough to deal with because they don't really want you to help them. Oftentimes they're going to be scared, especially if they're having difficulty breathing. Their anxiety is going to be amplified. And in situations like this, parents are also pretty stressed out. So the best thing you can do is really just be calm, talk them through it, give them oxygen. If they're not going to tolerate that mask on their face, that's okay. Have their parent hold it for them off to the side. Blow by is better than nothing. And really just kind of prompt them to breathe deeper if you can. Other ways that we can assess this and make a determination or a guess for the difference between epiglottitis and croup is that this is a slow onset. So unlike that first scenario we just talked about where we said it was probably epiglottitis, that happened really fast within a couple of hours, right? Whereas croup is going to be over a couple of days. The kid is going to feel sick. They're probably going to have a low-grade fever for a bit. And after about 3 days, the disease or the issue is going to be in its full swing. So they're going to have a sore throat. They're going to be coughing, and it's going to be that very particular type of cough. They're going to have trouble talking if their throat is really sore. It's going to be hoarse if they do. And they might also have a little bit of stridor. So if we had just kind of looked at that first level of that assessment of that scenario, right? 4-year-old having a fever with some difficulty breathing and not being able to talk, right? That could come across as croup. If we just got that information, we might be able to say, it's croup, it's relatively survivable. Let's get you checked out regardless, or, let's get you some oxygen, whatever, you should be fine. But if we didn't have any other information or we didn't ask, we might miss epiglottitis. So with croup, this is what you're going to see. So normal vocal cords in the throat, they're going to be pretty normal here, but they will inflame. They will not completely be closed. They will not become completely obstructed, which is why this disease isn't that big of a deal for long term, right? A lot of people survive this. It's still an emergency. We should still get them checked out, but they're not likely to immediately die on our hands here. With croup, treat with oxygen for up to 94%. Like I said, we don't want to just assume a kid is going to take a mask pretty well. We don't want to just throw it on their face. A lot of children don't like it. We can have them, a parent or you, hold the oxygen mask next to their face. Definitely calling for advanced life support would help. And if for some reason they've got a whole bunch of excess secretions coming from their nose, we do have a bulb suction that we can help get that out of the way for them.
Kevin, did you say like drive-by oxygen? Is that we referred to like when you put it next to their face and so they're just breathing in?
Yeah, blow-by oxygen. Drive-by oxygen is funny though. I like that. Yep. So holding it next to their face with high flow going, it just puts, it's going to make the room air a little bit more concentrated. We just want to get them as much oxygen as we can, although kids really don't like the masks. So that's acceptable too. When it comes to treatment of kids, there are some things, especially like when they're conscious, is that even though there is a right thing that we should do and we try to do, the child is going to make it relatively difficult. And so people at the hospital and people in medicine understand we can only do what we're able to do without hurting our patient. So if the kid is ripping off the oxygen mask, but they really need it, we're not going to tape it down to their face. We're not going to keep it there. we're going to do whatever we can to get them to breathe more oxygen in. So if that means holding it off to the side while they get some oxygen, that's better than nothing.
Is that a billable code?
It's just, it would be oxygen.
Okay.
Oxygen administration. Yeah. And then we want to document it as blow by. Yep. So this next one that we don't want to miss is epiglottitis. So the word itself just means an inflammation of the epiglottis. So it's that flap that goes between our trachea and our esophagus, protects the airway and allows us when we swallow to get food down the esophagus and allow air to go down our trachea. This is a true emergency because, as you can see in this picture, the epiglottis can swell so much that it actually becomes a complete obstruction of the airway. Almost as if somebody got a piece of steak stuck in their throat, completely occluding it, the epiglottis can do that same thing. The difference here between this and croup is that this is a bacterial infection. So it doesn't necessarily have to come from, somebody eating something bad or getting something in their throat. It can come from an object touching their epiglottis, infecting it, and it just really festering that bacteria. So adults can get this too. I remember a case where somebody like accidentally swallowed a piece of metal and it irritated their epiglottis. It was kind of gross and it got infected and it turned into epiglottitis and it inflamed. However, if it just comes from kids, they're putting tons of things in their mouth, they get a lot of bacteria. It can happen between the ages of 3 and 6. That's when we see it most common. And it's a rapid onset. So it will come around, symptoms will come around within hours, not necessarily days. They can have a fever because it's that bacterial infection. And the main thing that's really going to tell us here is the drooling. They might or might not have a cough, so we can't determine it based off of that. And they will likely have stridor as well. But the main thing here is drooling. They're not able to swallow because they have an obstruction, and this will likely mean that they feel like they can't talk. Now, this is a true emergency that we can't do much with because we don't have a medication, we don't have a maneuver or anything like that that can fix the epiglottis being so swollen that it covers the airway. So this child needs to get to the hospital as soon as possible. If you're far out, definitely want to call for advanced life support. Oxygen as best you can, same thing with croup. But then we need to treat this as a potential airway threat. So this means as fast as you can get to the hospital.
With advanced life support, would that be an AEMT and paramedic, or would you suggest like a paramedic at this point?
Anybody you can get. That's kind of what we get in Vermont. Anybody who's higher level than you. Even as an advanced EMT, there were plenty of times where I was like, hey, Gary at the comm center, I need a medic. And he's like, too bad. There are none on.
Yeah.
And so for me, I was like, okay, the highest level that I can get is myself. For you guys, it's a little bit better because you can go 2 levels up, right? If you get an advanced, that's great. If you can get a paramedic, even better. It's essentially calling for help because this patient is going to need far more than what we can do. But yeah, so anytime you guys are considering that this is a really important patient or life-threatening patient, you definitely want to call for advanced life support because they can do a lot that you might not be able to do, specifically with life-saving interventions.
How do you disseminate whether you just transport as fast as possible versus asking for help? Like,
That's a great question. Knowing relatively what your patient needs is going to be beneficial, right? So if it's a cardiac arrest patient, get them there as fast as you can with good compressions. If you need help because you only have 2 people, call for help so you can rotate out and get those good compressions. It's going to depend on how far away you are from the hospital, where the advanced life support is, what the patient needs. It's really kind of a challenging topic. For you guys, though, the best thing is always to call early for help and then cancel if you don't need it. It's always better to ask for help and then say, actually, it's okay, we're all set, and have them on their way versus getting to a moment where you realize, oh crap, we need help. And now maybe they got a call or they're 30 minutes out, right? So if you're coming from a rural area and your medic or your advanced EMT is coming from Chittenden County, right? Meet them on the way. That would be great. They can come when you start your transport, they'll start coming up to you. You guys pull over at a stop on the highway. The medic gets out of their truck, gets into yours, and you keep going right to the hospital. That's great. But if you're going to wait longer for a medic when you could just get them to the hospital, that's usually the better choice. It's just going to come with knowledge of what your patient needs. So if you recognize they need an IV, they need fluids, they need intubation, they need advanced airways, they need medications, they need to be sedated, they need any surgical things, we need a medic or we need to get to the hospital ASAP. And if the hospital is a shorter drive or a shorter wait than waiting for an advanced EMT or medic, always go for the hospital. When in doubt, prescribe diesel is kind of what I say. Tell your driver, step on the gas pedal safely, of course. So another upper airway thing that we're going to see is just a foreign body airway obstruction. So this is just the term for any time that the actual trachea is blocked by something. Could be a piece of steak, could be a Cheeto, could be whatever, right? Something that is blocking that person's ability to breathe. Luckily, there is a pretty tried and true method of stopping this, which is just abdominal thrusts, also known as, and nobody, Chris, this is recorded, right? Crap. The Heimlich maneuver is what it used to be called. I'm not calling it that because Mr. Heimlich says that we owe him money if we call it that. So it's the abdominal thrusts. Problem with the abdominal thrust for us is that most of the time, if somebody has a true obstruction, we are not going to see them in a timely manner enough to perform abdominal thrusts. If somebody on scene, a bystander, knows how to do it, likely that's good. We're going to show up to somebody who just had a really stressful situation. But unless we can get there within a minute or two, we're likely going to come across somebody who is unresponsive with an airway obstruction. We're always going to start with opening airway. However, if we cannot see something in their mouth, we are not going to attempt to remove it. So even if you see something way at the back of their throat, remember, we can only suction as far as we can see. We are not reaching down into their airway and trying to grab something out. You are going to push it further down. I don't care how good you are with your fingers, you're going to push it farther down. So we're not going to do that, okay? We're going to assess their airway and we're going to see what we can do. Now, if there is something in their mouth, you can do a finger sweep and sweep it out. But anything towards the back of the throat, we are not risking, okay? So we can suction as far as we can see. We can do a finger sweep as far as we can see. Otherwise, if they're unconscious with a confirmed airway obstruction, the best thing we can do is chest compressions. That's going to cause pressure, same as it would to do the abdominal thrusts, and hopefully is going to remove that object. But we can't really do abdominal thrusts on somebody who's limp and unconscious. It's not going to work. Ways that you can kind of tell if somebody has an airway obstruction without being able to see it, right? If for some reason you just showed up, somebody's blue on the ground and you try to bag them and there's a bunch of resistance and you can't get a breath in, that's a pretty good sign that there is an airway obstruction. And we don't want to force it, right? You're not going to try to pop it down into their lungs. That would be really bad. If you get like resistance, call for advanced life support and really start chest compressions. Oh yeah. Also, so like if somebody comes up to you and it's just like, help, help, I'm choking. What are you going to say to them? You absolute idiot. You buffoon. You're not choking. You get partial obstruction at the most, right? Keep coughing. Come on, get it out of there. Your body's doing its thing. But if somebody comes up to you and they're like, that's a pretty good indication they need abdominal thrusts, right? So here's a TikTok video. Don't care about the sound. So this kid tries to drink water with a bottle cap on it, pops it down his throat. He starts doing the universal choking gesture, which he's probably not even old enough to know what those words are. It goes like this. He tries to wash it down. That doesn't work. As you can see, he is panicked. Runs to his teacher as everyone laughs at him. And the teacher knows what to do. She does abdominal thrusts. And after, what was it, 5 there, 4? He's good. Coughed it out. So that's essentially how quickly it can happen and what needs to happen within the first couple minutes, right? If that kid was by himself or didn't have a teacher who knew what to do, he would likely run around until he lost consciousness and just went unresponsive, right? And we would be showing up, doing assessment of a non-breathing kid, and then figuring it out from there. It's very rare that we're going to be in the same place as a patient who called 911 and having a true obstruction, but these are really good techniques to know just for your general life. It can happen anywhere, really. Someone can have an obstruction. What they need is abdominal thrusts. So you come around the patient, you're going to take your dominant hand and you're going to make a little knobby with your thumb. I used to teach self-defense classes. Don't punch somebody like this. It will really hurt you, not them. So abdominal thrusts, okay, like this, not punching people. So a little knobby with the thumb. You're going to find their xiphoid process, which is that little triangular thing at the bottom of their sternum. You're going to find their belly button, and then you're going to come pretty much in between those two things. You'll put your thumb right there, and you're going to take your other hand and wrap it around. And essentially what you're trying to do is push in and up. You're trying to act as their diaphragm a little bit extra. So you need to do it pretty strongly and hard until they cough up that object and are able to breathe and talk again. If it's not working and they go unresponsive or they go limp, lay them on their back and start CPR. Essentially, that's what we can do for airway obstructions. Oh, we don't need to see this again. Okay, we got another case here. So a six-year-old male has been participating in a school science trip. According to his teacher, he's been falling behind the pack since they arrived. The teacher noticed him sitting on the ground, having difficulty breathing, not wanting to talk, and seemingly dozing off. His pulse is 150 and it's weak. His respirate rate is 52. Blood pressure is 90/60. Skin is pale and his breath sounds are difficult to hear. Sick or not sick?
Wicked sick.
Very sick.
Wicked sick. Yeah. What's the most concerning thing here?
Maybe the weak pulse.
Dozing off, whatever
Dozing
that
off.
means.
Dozing off. He's lethargic. He's trying to stay awake, sleepy. Breath sounds hard to hear. Yeah, that's pretty concerning as well. So good. That's pretty much it. I don't think there's an answer to this one. The whole point of this, recognizing this is a sick kid without doing too much, right? You show up, you listen to what the teacher says, you see him, he's pale, breath sounds are difficult to hear, his pulse is super weak and he's breathing really fast. Sick, let's get him going to the hospital. So those are kind of those physical upper airway obstruction kind of things. So a viral infection causing the throat to be kind of swollen, a bark-like cough, onset over 1 to 3 days, that's croup. A fast onset of a bacterial infection of the epiglottis, which could lead to complete obstruction, epiglottitis, and then just normal upper airway obstruction. Those were kind of that upper airway stuff. But then pulmonary causes, things that are kind of down with the lungs or other reasons, are going to be asthma, pneumonia, COPD, a traumatic thing, potentially like a pneumothorax, a pleural effusion, or breathing in something toxic. These can cause difficulty breathing. And we're going to see these. So we have talked about asthma a little bit. Our bronchodilator, that albuterol, is the medication that we have specifically for this. National Registry says pretty much anybody who is prescribed with one of these inhalers, you guys can help out with. And Vermont says if they need it, you can give it to them. So asthma can be caused by a bunch of different things. It can be exercise induced. It can be like allergy induced, pollen. It can be just due to a genetic predisposition, anything along those lines. And it's essentially just that constriction of the bronchioles causing difficulty breathing. This is really characterized by wheezing. Bronchoconstriction is just what causes wheezing to happen. And it's pretty common. This can happen to quite a few people. I remember I had exercise-induced asthma when I was like 5 or 6 years old, and I remember my mom walking me through using an inhaler, and I had no idea what I was doing it for. But very common, and here is some wheezing sounds. Specifically, for your clarification, this is what it would sound like through a stethoscope. So this person doesn't seem to be audibly wheezing, but if you were to listen to their lung sounds, this is what you might hear for wheezing. So if you hear that audibly with your ears, they could definitely benefit from a nebulizer, from a bronchodilator. Thank you. So for you guys, again, we'll make the delineation here. National Registry says you can only assist with a bronchodilator inhaler if it is prescribed to them. Vermont says you can give a nebulizer treatment of albuterol as much as you'd like with wheezing and symptoms persisting. Or if you hear wheezing and it sounds like they got wet lung sounds, you can do a duoneb up to 3 times that ipratropium bromide in there with that albuterol. Does anyone remember what the National Registry says about dosing for a meter dose inhaler? How many puffs, how many times?
3 puffs 4 times.
Yep. So up to 12 puffs as symptoms persist. Absolutely. Anyone remember the milligram dose for a nebulizer? .5 milligrams. Just one of those little Kool-Aid wax squeezy things in the nebulizer. Are there any contraindications?
Max dose already met.
Yeah, pretty much it. We'll use our critical thinking to see, do they really need it? Is their pulse too high? Blah, blah, blah. But yeah, essentially, unless you've hit your max dose already, or they're not having these symptoms that require an nebulizer, that's it. The next big difficulty breathing thing here is straight up anaphylaxis. So an allergic reaction that essentially the body cannot manage. It over manages it, essentially. People who have anaphylactic reactions, their body makes a mistake. Essentially, they get the allergen in their system and their body goes, oh my God, and it just does everything too fast and too much. So what's happening here is with that body reacting the way that it does, we're going to see this type of swelling. So this is called angioedema, swelling of the face and the mouth. What's happening is all the vessels of the blood vessels under the skin, when they have that allergic reaction, they just open up, they dilate really quickly, and fluid begins to just pool in those areas. So that's when we see this swelling of the eyes and the lips and the face. That's just a sign that there is a lot of swelling happening in that area. Those vessels are very widely open. We're going to see hives and other things like that. That's less so an important thing for us. It's still very important for us to assess to see if they have hives, but we're not giving them epinephrine for their hives. We're giving it because anaphylaxis is a type of shock, specifically due to those vessels opening and causing potential airway obstruction. So that epinephrine, that epi, is a vasoconstrictor and a bronchodilator. So this will stop that swelling and open up their lungs, preventing them from going deeper into shock. So that's why we're giving it. If somebody just has hives, not having any difficulty breathing, not having any airway obstructions, but they are allergic to something and have been exposed to it, does not mean that they need epinephrine. If they're having any sort of upper airway issues or difficulty breathing, and they have a history of anaphylaxis, it's a good point. It's a good time to give them epi because it can change really quickly. Epinephrine is one of the only medications that we have in our scope of practice that can be given as a life-saving intervention. So in our ABC assessment, pretty much every other medication, we want to go through a full assessment, ABCs, AVPU, OPQRST, sample. We want to get through all of those before we give the medications. Whereas with epi, we show up, we see somebody who looks like this with her face. She says, I got stung by a bee and I'm allergic to bees and my throat feels kind of raspy. I'm going to say, where's your EpiPen? And I'm going to give it to you. And that way, if her airway closed, or if her airway was going to close, we stop it. We can get her going to the hospital. I can do my assessment after I have opened up her airway and potentially saved her life. That's the main difference with epi. So in an NREMT test with difficulty breathing, if we didn't do a good assessment and it turns out that it's not asthma and we didn't ask about skin, or we didn't do an assessment of it, and they were having difficulty breathing and swelling of their face and flushed and hives, right? And we gave them a nebulizer, that would be bad because they needed an epinephrine, an EpiPen pretty much right away. So what is the dose for an adult of epinephrine?
0.3 milligrams
Yep, 0.3
of the 1 to
milligrams.
1,000.
1 to 1,000. Absolutely. What is the route? How are we getting it into their body?
Intramuscular.
Intramuscular, absolutely. And what's the pediatric dose?
0.15.
Yep. Great job. So the next condition here, this is called pleural effusion. So that's essentially when there's a collection of fluid outside of the lungs in that that lining, that pleura, and it's causing pressure to build up and make so those lungs can't expand. Now, this is different from a pneumothorax and a hemothorax because this isn't blood or air that's causing the lungs to not be able to expand. It's lymph fluid, it's body fluid, essentially. It's plasma coming from our blood. It's that backup. So this can happen if there's like an infection in that pleura, pus and other stuff can start like accumulating and going in, or it can be kind of from the fact of people who just have a lot of fluid, whether it's from heart failure, backing up into their lungs, causing there to be just a constriction inside their chest cavity. So it can be due to infection, just irritation. It can be due from CHF, can be from cancer, specifically lung cancers. How we can assess it is that there is going to be decreased breath sounds to the lower lobes. Water, even the water in our body, tends to follow gravity. So the base of our lungs is typically where we're going to see fluid build up. So if somebody's having really wet lung sounds, you're less likely to hear the wetness up high in these lobes. You're going to hear them lower down in the bottom half of the lungs. So same thing with this. So why might having the patient sit straight up make them feel better or make it feel like it's less difficult to breathe?
Liquid to the lower part of the lungs.
Yep. Right. So if somebody's laying down flat, gravity is going to spread that liquid out. So it's going to cover more surface area of their lungs, making it so more of their lungs can't expand. Whereas if you're sitting up straight, that fluid's going to fall down. And while it is still obstructing a lot of the lung movement, it's not doing as much. So a lot of times you'll see these patients sitting straight up on the stretcher. If this has been going on for a while, these are the patients who sleep in a recliner, right? They just make their living room their home. They sleep in a recliner, so they don't have to lay completely down. They just sit straight up and it helps with their breathing. For our purposes, there's not much we can directly do. Body positioning, oxygen, potentially calling for ALS. Those are some good things. ALS in this situation might be able to use CPAP if they meet the criteria. And fun fact, this is the other time that in our protocols, nitro can be used for something that isn't chest pain. It's kind of interesting. If somebody is having a lot of fluid in their lungs and they meet the criteria for a CPAP machine, an advanced or higher can give nitro in combination with CPAP. And the purpose of that is to open up the blood vessels so that when you combine it with CPAP, you actually push the fluid back through the cell walls and it diffuses the liquid out of the lungs. Really rare instances can use this, but it's actually really cool because that pressure of that CPAP gets down into the bases and it forces that fluid out, pretty much pushing it away. And that nitro opening up the vessels makes it so that they can accept more fluid. Now, similar to pleural effusion in a way, pneumonia is due to like an infection, but also has a lot to do with like obstruction of the airway this time. Whereas pleural effusion is more so, imagine the lungs being dunked in water. Imagine this with the alveoli being infected and being like caked with mucus and pus. It's really gross. Kills a lot of people, a lot of elderly people. And what's the main concern with having a bunch of mucus in our alveoli?
You don't have the proper respiration.
Yeah, you don't have enough oxygen going in, right? The air might be getting to those alveoli, but mucus is really thick and air can't really permeate through it. So those alveoli are essentially useless and they're just covered in grossness. So a lot of people die from this. This is what actually was killing a lot of people from COVID, was the fact that you develop pneumonia due to the infection. This kills a lot of elderly people every single year. So poor ventilation leads to poor respiration. and it's going to lead to high respiratory effort. So especially in susceptible populations like the elderly population, if they need to work really hard for every single breath that they have, and it's going to be a long time, these patients will just lose their ability to have a respiratory drive anymore. There is a line where no matter how much we want to breathe, our body physically can't. Just how you can try lifting weights as much as you want, but there is a point, no matter how many weights you lift, there is a point. If you kept doing it, you would not physically be able to get your arm up, right? Same thing with this. If you need to breathe, if it takes that much work for you to take every breath in over a period of days to weeks to months, can lead to somebody just losing the ability to breathe and going into respiratory failure. Also, this can lead to sepsis because it's an infection of the lungs, and the lungs are pretty so closely tied to our circulatory system. This infection could spread into our bloodstream and lead someone to have just a massive body-wide infection called sepsis. And sepsis has a very high mortality rate. A lot of people die from it. It's very hard to survive. So pulmonary edema, this is just another term for fluid buildup within the lungs. So pleural effusion is a little bit different. It's fluid on the outside of the lungs can go inside, can build up, but then pulmonary edema is when there's a lot of fluid on the inside of the lungs. This is usually the result.
Oh, sorry. I just had a question. Is pneumonia like a kind of pulmonary edema, but not all pulmonary edema is pneumonia? Is that sort of where we're at with this?
Sorta, yeah. The main difference there is that like pneumonia is going to be due to an infection, and that infection is causing mucus and like a pus buildup, whereas pulmonary edema is going to be more so from like the body backing up and having lymph fluid and plasma in there versus like that, you know, gross pus. One is just due to another system failing. So pulmonary edema is usually due to a result of congestive heart failure. Well, pneumonia can be a side effect of this, like if you're getting an infection, but for the most part, they are different. That makes sense.
Thanks.
Yeah. So this is when just essentially water, lymph fluid, plasma gets built up inside of the alveoli. So this is when we're going to hear really wet lung sounds. It sounds like somebody is breathing through water. If you can picture that, like if somebody had a water respiratory tank and they're breathing it in, sounds like it bubbly, crackly, they're coughing up stuff. It's really gross.
Is that also diagnosed with an X-ray like a pneumonia would be?
Yeah, we're not really going to be able to diagnose it.
Right.
We're going to need higher imaging. So yeah, they're going to take a look in and say, okay, yeah, you've got pulmonary edema. Can usually be diagnosed by listening to it. It's like, it sounds like water. It's hard to describe. Like when you listen to somebody's lungs and they're having pulmonary edema, yeah, you're like, you got water in there. It's like, it's pretty easy to tell. So treatment for this, again, oxygen. This is another time we'd potentially use CPAP for advanced EMTs. So when it comes to respiratory emergencies, guys, if you can't tell, there's kind of a theme. It's for you guys, oxygen, BVM if you can, and then call for ALS is essentially it. You should definitely call for ALS when it comes to respiratory compromise. Whether or not they come, that's dependent on the situation, but you're going to need some help. Advanced EMTs and higher can do a lot more to help these patients. Now, does anyone have any questions so far? We're kind of going through these. Okay, so the next topics are going to be some of the biggest like call percentages that you're going to see. And that is the broad topic of chronic obstructive pulmonary disease, or COPD. There is a large population of patients in America who have COPD, and they call ambulances quite frequently because this leads to so many different symptoms, very, very like not fun symptoms for the patient. It makes you feel really, really bad. So this consists of two diseases. So COPD is an overarching term for two different conditions. And we're going to talk about those. But essentially, what causes this is damage to the airway, usually from toxic inhalation over a long period of time, like smoking, but also working in like unclean air, A lot of people in very polluted areas will get this too, especially if they live their entire life breathing in all those toxic fumes. And it's really divided up into two things because two different injuries can essentially happen to the lungs. There's emphysema, where it's classified by alveolar destruction. So those alveolar sacs way down at the base of our bronchi, those get damaged. They lose their elasticity, they lose their surface area, they lose their ability to open and contract. Or chronic bronchitis, which is going to be an excess of that mucus and phlegm and fluid just constantly build up in these persons' lungs. So there are different ways to assess and tell for these two diseases, but pretty much if somebody has COPD, they either have chronic bronchitis or they have emphysema. So we'll talk about it. Now, people in EMS, we affectionately refer to these patients by how they can present, blue bloaters or pink puffers. It is just essentially how these patients present. And it's pretty tried and true. So in how they present is going to show us kind of the differences between these two diseases. So with chronic bronchitis, these are people who have constantly clogged bronchi and bronchioles. So it's almost constant that they have a productive cough, right? They constantly have something down in the lungs, and they're constantly trying to cough it up. So what that tends to do is that it builds up muscles in the chest. It does that, right? Constant coughing is going to make their chest a little bit bigger. These patients, not entirely, but they are also typically overweight. It's not a set thing that they are, but they tend to present that way. It goes along with their chronic obstruction. They're going to be cyanotic. So these patients are not going to be getting enough oxygen. So they're going to be blue, typically around the lips or in the face. And they're going to have a baseline low SpO2. So these are those patients that we're talking about who are going to be on home oxygen quite frequently. They're going to say, you know what, my SpO2 is normally around 88 on 2 liters. Whereas emphysema, this is that damaged alveoli. So it's not that they're having trouble getting air down to their alveoli. It's that once it gets there, it's not being absorbed as easily because there are fewer of those alveolar sacs. They've kind of combined. They've lost their surface area. And it can get to the point where if their alveoli kind of get floppy, they're not as elastic and they can't expand as much. When you breathe out, they kind of get stuck together. And so then breathing in takes work to try to get them unstuck from each other. So you're going to tend to see patients with emphysema breathing with pursed lips because they're trying to create a back pressure. So breathing out with a pursed lip, you can actually kind of feel it in your own lungs, right? So if I'm breathing out like this, I'm trying to keep pressure in my lungs so that I don't completely breathe out, so that my alveoli collapse. And so then when I'd have to breathe in to try to really expand them again. So having that pursed lip, it keeps those lungs expanded. So you're going to see that quite frequently. And that type of breathing is going to lead to a barrel chest. So while chronic bronchitis, they kind of get all that coughing because they're trying to do it a whole bunch. People with emphysema are going to be working extra hard to get those breaths in and out. And therefore they're going to be using a lot of their muscles, their accessory muscles. And so they actually kind of develop a barrel chest over years and years of this happening. So the whole reason behind this kind of offensive way to refer to these patients is just because this is how they present. This is a lot of times what we're going to see. With the chronic bronchitis, they're going to be chronically cyanotic, so they will likely be bluer. And then with emphysema, they're trying to force all this stuff up, and you're going to see, or they're trying to force themselves to breathe. And with these damaged alveoli, we tend to see pink, frothy sputum coming out the side of their lips. So if you see that on somebody, it's likely that they have emphysema. And this is oftentimes what they can present like. We're going to see two distinct body types for these two different disorders. We're going to see that barrel chest on the people with emphysema, and we're likely going to see that blue coloration, that cyanosis, and typically a little bit on the overweight side for chronic bronchitis. These are very common disorders. You likely know somebody in your life who has either suffered or is suffering from them. If you work on an ambulance, you're going to see it quite frequently. So our treatment for COPD is pretty much a combination of everything so far, because there is the chance for bronchial constriction. There's also the chance for fluid in the lungs, right? Low SpO2s. What we're going to be able to do is give them oxygen and potentially albuterol or a nebulizer if we think they need it. These are the patients, specifically like chronic bronchitis patients, that will benefit the most from that duo-neb, because they have that excess mucus and potentially some of that fluid in their lungs. A duo-neb does both, right? Opens up the vessels and then also dries the lungs out a little bit. So if they've got wet sounding wheezes, duo-neb up to 3 times. Otherwise, oxygen and transport, call for ALS. The difference here is that depending on our patient, right? If they have a chronically low SpO2, we are not doing the same level of correction as we would for somebody who doesn't have one of these conditions needing oxygen. So the difference for us here is that we're not trying to maintain necessarily 94% as we would on a healthy patient. We're trying to maintain their baseline. And our protocol book says roughly between 88. Crystal, your dog's barking at us.
Oh, sorry, I didn't know I was not muted.
No worries. I got shocked by the loud dog bark. So yeah, our protocol says roughly maintain 88 to 92%. But we're going to ask our patient what their baseline is, and we're going to try to maintain that, right? So if somebody says my normal on 2 liters at home is 88%, we get there, they're having difficulty breathing, and their SpO2 is like 85 on 2 liters. That's when we're going to crank them up to a little bit higher, right? Probably give 10 liters NRB, because we're aiming for 88. We're not aiming for 94 because their baseline is lower. If we were trying to force that oxygen up to 94, that is when the concern of the hypoxic drive kicks in, that we're giving them too much oxygen. But we want to maintain them around their baseline. But if their home oxygen isn't getting them to what they're normally at, we want to supplement some more.
Question. So we're transporting them with the idea that they're going to need to follow up with a provider to change their at-home protocol, because we're like, is that why we're transporting them at this point? Because
we're transporting them. Well, we're transporting them because this is a medical emergency, because they are having difficulty breathing and their oxygen level is not enough to maintain their baseline. That can lead.
Right. It's a chronic condition though, right? So it's constantly at risk, right?
Yeah, but there are plenty of people with COPD who don't have exacerbation of it, who go along their life living with their oxygen without having major difficulty breathing. Like, there's a difference between coughing every day, having this congestion in your lungs, being on home oxygen, and then not feeling like you can breathe, having bronchoconstriction, and having a low SpO2 lower than your baseline. Yeah, like on a lot of the times with chronic conditions, we are going to be transporting somebody for an exacerbation of it. But we as basic EMTs do not have the level of training to say, you are going to be fine, follow up with your provider. If they're having a respiratory issue, that falls within our airway breathing circulation. And if they want to go to the hospital, we bring them to the hospital.
What's the threshold for calling for ALS?
I'd say if it's really like their SpO2 is low, very low, below their baseline, oxygen isn't helping, any interventions that you are doing do not seem to be improving this patient, you can call for ALS. This is a little bit different now because within the past couple of years, you as basic EMTs in Vermont are given that duo-neb treatment. Duo-nebs work really well for these patients. But again, if they need CPAP, which is really beneficial, you can't give that. You can't even really assess for, do they need it? You can register, okay, they're having substernal retractions, their SpO2 is here, their breathing is this, but you can't get that to them. And they could really use it. If for some reason they decline, they go into respiratory arrest, I would much rather have a medic there who could intubate them versus using an OPA or an MPA. There's quite a few things that advanced providers can do to help these patients, because yeah, for the most part, they are chronic conditions. But when you have a bunch of chronic conditions, it's kind of hard to tell what's going on. And you can die, and you will die from a chronic condition at some point, right? If difficulty breathing goes untreated, it can go to respiratory failure to somebody dying. It can happen very quickly. And
So what you're saying is that if we're unable to get them back to baseline, that we given our interventions, that we should call for ALS because people can go downhill quickly.
yeah, exactly. And so again, like, it's always safer to call and then say, actually, you know what, you guys can cancel, we don't need you, versus getting in the truck, them declining because they didn't get a CPAP machine, going into respiratory arrest, and now you are bagging somebody hoping they don't go into cardiac arrest, saying, hey, can we have a medic? And the medic's saying, we just got a call. Right? It's always better to call and then cancel than it is to not call at all. Personally, I've been called for like advanced EMT intercepts, and there have been plenty of times where like, hey, can we get an advanced EMT? We get on the road, they say, they radio back and say, you know what, we're going to be faster going to the hospital, you guys can cancel. Every single time I'm like, great, I don't have to go on a call. But I'm also like, if they needed me, that was the best call, right? If they needed me, that was the right thing to do. Okay. This next one can be caused by a couple different things. It's called a pneumothorax, and it's air, specifically just air, being trapped between, well, in the chest cavity, causing pressure on the lungs. Because our chest cavity is so airtight and it really needs to be, cordoned off, if there's air that gets into it, it really sucks it in, right? It's essentially a vacuum. We pop a hole in it, air rushes in, and it won't leave as easily as it comes in. So every breath somebody takes, you're changing that pressure inside your lungs, and you're actually in your chest cavity, and you're actually allowing more air in. So with every breath, the lung affected actually gets smaller and smaller. It becomes unable to expand as it normally would. This can be caused by trauma. So whether it's a physical puncture wound into the chest cavity, whether it's due to blunt trauma causing something to happen. But this also is actually a very frequent thing that happens in young, white, lanky males. They are very much affected by spontaneous pneumothoraxes, statistically. And when I was working at the high school, this poor kid had it happen twice in the same week to him. He was playing basketball and he just twisted. And according to the athletic trainer who was in the crowded auditorium or the basketball court with him, said you heard an audible like pop, and it was his lung getting dislodged from the wall of his pleura essentially, and it just filling with air. And so then he had to go get surgery, chest tube, and then it happened like the next week during his recovery. This actually happens quite frequently.
Kevin, when that happens, where does the air come from?
Usually from inside the lung. It rips a little bit and it goes out. Can also just be like a rip in the pleura. And so it's not necessarily that the whole cavity gets filled with air really quickly, but a little bit can happen. But yeah, it's usually from inside the lung. So the lung gets damaged. It's usually due, for these spontaneous types, is due to growing too quickly. Essentially, you grow really tall and really lanky, and then your pleura doesn't grow big enough, essentially, and it just kind of happens. I'm reading the chat here. Yeah. It's just one of those things. Body types can make this happen. It also can occur with infections. So if there is an infection on the inside or on the outside of that pleura, and it causes enough space to happen, air can accumulate there. And the main signs and symptoms of this is that they're going to have difficulty breathing, potential pain in the affected area, depending on what caused it. But essentially, the main thing is going to be listening. Like if you hear lung sounds on the right side up and lower, but then you hear no lung sounds on the left side at all, or diminished lung sounds lower in the lobes, it's a pretty good sign that they've got something going on down there, whether it's a collapsed lung or not. Now, why would the position of the trachea be important in this? If you guys remember, during our trauma assessments, when we're assessing the neck, we're assessing for JVD, jugular vein distension, and also tracheal deviation. Why would this be important?
If the trachea is deviated, maybe air's not getting into one of those lungs through the trachea. So it's not that it's collapsed, it's that it's just not getting inflated.
Okay, that's close. I like your mindset on that. That's not exactly the reason.
But it shows that you're in late stage because the trachea is already shifted over to better support the functioning lung.
Sort of. So it's not that it's adjusting itself to better support, but it does tell you you're in the late stage, because if enough pressure builds up on one side of the chest, it's actually going to increase. And we see the trachea moving off to the side, the opposite side of where the pneumothorax is. So if you're looking at the trachea and it's deviated off to one side, the side that it's moving away from has too high of pressure, and it's actually causing a different condition called a tension pneumothorax. That's dangerous because, one, I mean, a pneumothorax, you're losing half of your ability to perfuse oxygen. But what can happen is that trachea can actually start putting pressure on the heart and therefore causing it to not be able to beat. And that's really bad. Now, with pneumothoraxes, there is luckily a very quick and relatively easy procedure to essentially fix this. We cannot do it. It has to be a medic. They do a needle decompression. They take a big 14 gauge needle, they put it into the chest cavity, they open it up, and the air rushes right out. You can listen to it. You put it in, you turn it, and you hear air leaving the chest or blood, whatever it is causing the pneumothorax or the pressure in the chest. So this is definitely a condition to call medics for. Advanced EMT would not be able to help as much in this situation. So if you know that you've got a pneumothorax, definitely call a paramedic. What else was I going to say? So oxygen with this as best as we can. However, BVMing isn't going to help that much, because no matter how much force we put into the lungs, right, it's not going to change that pressure buildup on the damaged lung. It will help expand the healthy lung, and younger people, specifically like those 18-year-olds, they'll be okay. They can pretty much manage with one lung. But if somebody has respiratory issues, or they are in the elderly population, even like middle-aged to elderly, they're going to be less able to compensate for as long. So assessment for this, definitely listening to lung sounds. This is where your guys' stethoscope and auscultation will really come into play, because you're specifically listening for, is air going into all different sections of this lung? Does it sound equal and bilateral? If somebody was unconscious, we could assess, not even just if they're unconscious, but we use this a little bit more if they are, looking at their chest rise and fall. Is it equal and bilateral, right? Somebody's lung on this side isn't expanding, or it's pressured, and they take a deep breath, we're only going to see expansion on one side of the chest. It's going to be kind of lopsided. So that's a good assessment there to tell us about pneumothorax. And then that tracheal deviation just tells us, oh boy, this is a very progressed pneumothorax or hemothorax. We need extra help. That's bad. The next thing we're going to talk about is a pulmonary embolism. So this is essentially the heart attack of the lungs. So as a heart attack is a clot blocking the vessels of the heart, this is a clot blocking the blood vessels of the lungs. So all of the blood vessels that take the unoxygenated blood, get it oxygenated, and then take it back to the heart from the lungs, if those are blocked, we are simply just having the amount of oxygen-rich blood being reduced. So this is another very common thing, and it can cause sudden death. Somebody can have this kind of like weird pain that doesn't seem to go away. It can be kind of mild, can be kind of numb, to them not getting enough oxygen very quickly and going into essentially a sudden cardiac arrest. Some risk factors of this is recent surgery or long bone fractures, anything that's going to increase the amount of clots kind of just randomly in our body. Confinement to a small pressurized space for a long time. So like a plane ride, a lot of people will say, oh, you know, I got off that 15-hour flight and I had this kind of pain in my leg. It went away, and then I started having some pain in my chest. They go to the hospital. It's a pulmonary embolism. It often happens due to a clot somewhere else in the body breaking off and then getting lodged in the lungs. Another risk factor is tobacco use, oral contraceptive use, And being pregnant or postpartum, you just have an increased clotting factor. Here is a picture of an insane pulmonary embolism. That you can see the shape of the lungs, right? That was the clot in the blood vessels of his lungs. So they just pulled it right out. All of that surface area in his lungs was not perfusing oxygen. That is very bad, right? So that's essentially what it looks like. We've got our lungs, we've got our bronchi, and then we've got the blood vessels that are connected to all of it. And those are what have the clot in them. It's not any of the internal airway structures, it's the vessels, the blood vessels around those structures. Now, I've talked about this a little bit, but this is a big condition to help us rule out or rule in cardiac chest pain. So this can kind of present in a similar fashion of somebody saying, I have really bad chest pain and my SpO2 is low and I feel really short of breath, right? I don't feel like I'm getting enough oxygen. So if you were to just hear that, you're kind of thinking, oh boy, you're having a heart attack. But there are some pretty distinct ways that will help us determine the difference. And the main thing is the type of pain. With that cardiac pain, we're going to see standard crushing. It's really heavy. It's like a big weight on my chest. The pain is usually in their left side, radiating either to their back, to their jaw, or to their left arm. But with a pulmonary embolism, we're going to see something called pleuritic pain, which is essentially when somebody says very pinpoint stabbing pain. It's like, if all this skin and muscle wasn't here, I'd swear that there was just a knife right there. I don't know what it is. It's just stabbing right here. It doesn't move anywhere. It's right there. That's a good way to tell between cardiac and pulmonary, especially if they're having a pulmonary embolism. So due to the nature of this injury, we can't have any direct effect on it. Even if we do give them oxygen, right, the area of their lung that isn't diffusing oxygen isn't going to benefit from it. But what we're trying to do with the excess oxygen is we're trying to essentially not overload, but excess load the other side of the lung, right? Give it as much oxygen as it can. Because if one lung is still working, we can give them oxygen. It will still diffuse. It might not be the same amount if they had two lungs, but the closer we can get to normal, the better. We can really support the breathing and monitor their vital signs, call for ALS, but even then there's not many medications or anything like that that ALS can use to fix this. This is one of those times we assess, we monitor, we load and go. Because it can lead to a sudden death. But yeah.
Why no aspirin?
It's not within our scope of practice. Plus aspirin doesn't bust clots. It doesn't stop it. It would potentially stop this from getting bigger, but not within our scope. Okay, after this case, no, we'll keep going a little bit and then we'll take a break. So what do we think here? 65-year-old man with a history of a cardiovascular disease and COPD develops severe dyspnea. Our initial assessment is the patient is pale, he's overweight, he's sweating, and he's sitting upright. His pulse is 125, his blood pressure is high, 193/107, his respirate is 28. He can speak only 2-word sentences. When you do a physical assessment, you see distended neck veins. You hear wheezing on his expiration. You see accessory muscle use and ankle edema, swelling of the ankles. What is the biggest concern here? What do you think?
His breathing.
Yeah, that's a good one.
Needs to get in the ambulance and go.
His blood pressure, because his ankles are swollen, so he's having blood flow issues.
Okay, yeah, that's another good thought.
Distended neck veins are a huge red flag.
Yep, right. So that JVD, all of this is telling us that he's not only having a respiratory issue, but he seems to also be having a cardiac issue. It's not a straightforward heart attack. Oh man, I've got a blockage in my heart, but something else is going on with his circulatory system. He is swelling in places that he shouldn't be. His neck and his ankles. He's having severe difficulty breathing. His blood pressure is high and his pulse is high. So he's definitely sick. Cool. So we'll do the traumatic causes and then we'll take a break. So when we're talking about trauma, specifically when it gets to lung and pulmonary issues, the main two injuries that we are going to be concerned with are a flail chest, which is also called paradoxical movement. So if somebody says paradoxical movement, it means flail chest. And if someone says flail chest, it means the same thing. They are the same thing. They will be referred to as both of those things. And this is when there are two or more ribs broken in two or more places. So essentially, that means that the chest gets all wobbly and wavy. There's no actual structure. So like we can see in this video, this is a flail chest. You guys see that okay? So specifically with this one, we can see that when he's breathing out, his chest is moving down, or sorry, moving up. And then when he's breathing in, his chest is moving in. So that's where that term paradoxical movement comes from. It's opposite of what should be happening. And that's because all those ribs are broken. So the structure isn't there. That isn't necessarily a main concern for like lung injuries. It's very hard for like the ribs to get broken so much that they will puncture the lungs. But what this ends up doing is increasing the speed at which somebody fails at being able to breathe. All of those ribs broken is incredibly painful with each and every breath. And if every breath is painful and hard to get in, you will likely stop breathing faster. So the best thing that we can do for these patients, even if they're conscious, is bag them with a BVM. It is control their rate of breathing so they don't have to use those muscles. They allow us to use the force of our BVM to expand and contract their lungs. And the other thing we could do is pad that area lightly with just protective blankets or gauze just to make sure that no other things hit it and exacerbate that injury. These are one of the life threats that will always be or potentially always be presented to you in your trauma assessments. So both of these things on your trauma assessment test, you will know how to fix. You will need to know how to fix it. So flail chest, pad the area, and then do something we call splinting by BVM. Give them a BVM. Now, a sucking chest wound, this is essentially just an open wound from the outside world into the chest cavity. So usually it's that nice protected airtight seal. But if we have a wound that goes from the outside world into our chest cavity, air can get in and sometimes it can bubble out. So we're going to see bubbles around that area, or we might hear air entering or leaving. You might hear like a whooshing sound with each breath. This is very common in gunshot wounds and stab wounds. And we are going to treat this with a BVM, but after we apply an occlusive dressing. Do I have that on the next slide? No. So what we can do here is we can apply a dressing called an occlusive dressing, which is essentially a big sticky pad that goes right over and it stops air from getting in. We're more concerned about making sure that air doesn't get in than we are about letting air out. We can have a medic come and do a decompression so that we get the air that's in there out already, but we just want to stop the pressure increase. If every time they breathe out, since they're decreasing the pressure, air is rushing in, it's going to make their lung get smaller and smaller and smaller, and therefore lead to them having a more severe pneumo or hemothorax. So we want to cover up that wound and make sure that it's airtight. And then we can supplement with a medic, either doing a decompression or we bag them and get them to the hospital. So treatment for this, occlusive dressing, and then BVM. Now, you can use other things in a pinch if you don't have occlusive dressings. And unfortunately, in patients with multiple gunshot victims, they will likely have more than one of these injuries, whether it's one in the front and one in the back, or two in the front and two in the back, right? Bullets go through and they can have the same effect on the back area. So you'll likely need to use a whole bunch if you've got a patient who has a whole bunch of these. You can use any sort of sterile plastic with some tape. So if you took like the inside of one of the bags that comes sterile, whether it's for like saline or something like that, and you put it over the wound and you tape down 3 sides of it, that can work as well. Really what it's just doing is it's putting that plastic layer over, so when they take a deep breath in, it gets sucked against it and it doesn't allow air in. And then if for some reason they were able to exhale and air was coming out, that 3-sided would allow some air to come out, where it doesn't allow air to come in. But hopefully you won't need to do that. You should be stocking plenty of occlusive dressings in the ambulances. So if you need them, definitely use them. But why don't we take a break? Let's come back at 7:15. Sound good? Sweet. So the other thing with breath sounds and advanced EMTs is it kind of makes it a advanced level call if an advanced EMT listens to lung sounds. So even if they weren't having difficulty breathing and an advanced EMT listens to lung sounds, that is determined an advanced life support thing. But if a basic EMT listens to lung sounds to determine presence and quality, that's not. So the difference between a basic level call, if we're talking about patients who are not severe here, the difference between advanced EMT listening to somebody's lung sounds is going to be about $500, $600 of a bill difference for the same call. So what I used to do is have a basic EMT listen to a lung sounds on patients who were not having respiratory distress. And if they heard something weird, I would just tell them, hey, if you hear anything that you don't know what it is, tell me you hear something weird, and then I will listen and make an advanced call. But if they don't hear anything, it's just presence and equality, great. Basic level skill, keep it that level. So there are some things to consider, and it's just also like not necessarily just what you know and what you hear, but it also makes a difference in what the patient gets billed and what the classification of the call is. So if you're able to listen to lung sounds and there's nothing there for an advanced to listen to, they don't necessarily need to, but if there's anything weird, always double down and have the advanced provider listen and make a determination. Cool. Any other questions that bugging you guys during break?
What are we padding? You said with the flail chest. What does the
Yeah,
pad do?
The pad is just to protect it from anything that might touch it. So we just want to make sure we're protecting it because it's a whole bunch of broken bones already. So just putting blankets, pillows around that affected area for the transport so that we don't accidentally like hit it, or just to protect it essentially.
Okay.
It's not really going to do anything medically for them. It's more of a comfort thing and protection thing. The thing that they really need is that BVM.
Now during the transport with that padding, would you just loosely put the belt over it, or would you just be like no belt?
I mean, they should always be.
They should. Yeah.
Yep. So that's the answer. They should always be buckled and secured. However you got to do it, make sure they are buckled in and secure. Because if everyone else is buckled, but the trauma patient isn't, and the ambulance gets into a wreck, and that trauma patient goes bouncing around the back of the rig, you got bigger issues than that flail chest. Yep. Great question, though. We always want to make sure they're secure, but we don't want to exacerbate any injuries. So just like when we're going to talk about splinting, we don't like tie anything down over the direct injury. Same thing. We'll just find a different way around it. Yeah. Okay. So we're still in respiratory stuff here just for a couple more slides, but these are some other things that you might run into. Psychogenic causes for difficulty breathing. This is an interesting one. Anxiety can come across very respiratory distressy. That was a very medical term, a very medical statement. Respiratory distressy. Its main time that we see difficulty breathing or a psychogenic respiratory issue with anxiety is hyperventilation syndrome. It's also called voluntary hyperventilation. Well, it's a little bit misleading there. The patient isn't wanting to do it, but it's because of their anxiety that they are. So it's actually really interesting. When somebody is breathing way too fast and getting too much oxygen, they can lose consciousness, and they can sometimes exhibit things that can be construed as seizure activity. This has happened a couple different times in the different places for me. But patients with anxiety who have panic disorders, they can hyperventilate themselves into going unresponsive. They will wake back up and then they could do it again. When they have too much oxygen, when they're breathing too fast, we start to see some what we call carpal pedal spasms. So their hands will actually start to clench in on themselves sometimes. And it's not voluntary. It's like it's muscles kind of retracting. So you might see them do that. And you also might see them shaking because they're squeezing so much. They might lose consciousness, and it really depends on the severity of their anxiety. A couple of years ago, I had a woman who was just panicked beyond belief, having an incredibly bad panic attack. She didn't want to like talk with us. When she saw us, she started breathing faster. She would back away. It actually got to the point where she breathed so much that she would slump down and go unresponsive. So then we'd go and we'd get her on her back. We'd start trying to figure out what was going on, open her airway, get oxygen. She'd wake up, look around, breathe normally for a couple of minutes, realize what was happening, and then start to panic again and then go unresponsive. And it kind of just went into this big circle. And this was when I wasn't the crew chief. I was relatively new. So I was just like, what do we do? And it's weird, right? If you want to give somebody who's breathing too much oxygen, but the reason she's losing consciousness is because she's having too much oxygen. So oxygen isn't going to help. What actually helps in this situation, and it's not technically allowed on the ambulance, but it's what you see in all those movies, right? Breathing into the brown paper bag. They're getting too much oxygen. So doing that breathing slowly into that brown paper bag reduces the amount of oxygen they're getting. It actually increases the amount of carbon monoxide, dioxide, and it will keep them a little bit level. So what you could do, inflate a NRB, have them breathe in and out of that. That can work. Otherwise, walk them through slowing down their breathing. That's essentially the best thing you can do. And then only like doctors can actually say, breathe into a brown paper bag. But so go ahead, Nate.
I was going to say that we had the same situation about 2 weeks ago, and the only thing that resolved it was actually having his friend ride with us in the ambulance. That was the only thing that calmed him down. So
yeah.
Psycho part of it that calmed him down.
Yep. So a lot of times the best thing we can do, if they are still willing to talk to us, is just PFA, psychological first aid. Whether it's, yeah, sure, your friend can ride in the back of the ambulance with us if that makes you feel safe, or just talking, whatever it is. It's not a respiratory emergency, but it is an anxiety disorder with a respiratory kind of part to it. If they kept hyperventilating themselves in and out, they will eventually stop. But it can still be really distressing for them in that moment. The other thing I was going to talk to you about is a student at the high school when I worked that would have this pretty consistently, but he had really strong reactions to it. So a couple of times they were with their guidance counselor, they'd go into their panic attack, and then we'd show up because they were unresponsive, not waking up, not to painful stimulus, not to anything, and they were having what looked like seizure-like activity. So we did have to end up calling the ambulance a couple of times, but essentially what the doctor said is this is hyperventilation syndrome. If this happens, have them start breathing into a brown paper bag. It will help them calm down. Combine this with other anxiety reducing techniques. So it can look and feel very severe for these patients, usually not a life threat. And the best thing to do is just calm, try to be calm and have them take slow, deep breaths. So baseline treatment for respiratory issues, we are always going to protect and manage the airway. So if they are conscious and they are having respiratory issues, we can give them oxygen, all that kind of stuff. But if they're unconscious and they're having airway issues, then we're going to have to control it for them. So any patient who's having respiratory distress should get oxygen. Any patient who's suspected of hypoxia or not having enough oxygen should get oxygen. And oxygen should never be withheld from somebody who needs it. Even if their SpO2 is not 94, it's like 95, but they're having major difficulty breathing, give them oxygen. Other than that, I've been saying this a good amount for respiratory stuff. It's always beneficial for basic EMTs to call for advanced life support. A lot of times that CPAP or the difference in airways that they can administer in emergency situations can make the difference between life or death. Somebody who's intubated has a much more controlled airway than somebody who has just a nasopharyngeal airway with supplemental suctioning. We have a bunch of tools to help out with this though. So if they really need it, oxygen, BVM, and assist them with their medications or prescribe them a nebulizer if they're having the wheezing, those bronchial contractions. And it's always appropriate to consult medical control. Remember, during pharmacology, I told you guys about that call of the 98-year-old woman with a pulse of like 180 who needed albuterol, but I called them and I said, this doesn't seem like the best thing to do because I don't want to up her sympathetic nervous system with her pulse being so high and her being so essentially frail. And I said, yeah, don't give it, right? So if you're ever concerned, call medical control. They're there for you. Okay, but that's it for respiratory. So now we're on to cardiac. So a little bit of review, also some more information. So heart disease, before COVID, was the leading cause of death in Americans. And not every chest pain call leads to cardiac arrest, and not every cardiac arrest comes from chest pain. A lot of times, cardiac emergencies will come across as just that standard, I've got chest pain, but sometimes they can present as respiratory issues. Just a review of the circulatory system, right? It's the pathway of tubes and vessels throughout our body. It functions to carry oxygen and remove waste. The pump of that system is the heart, 4 chambers in this organ. It's got its own blood supply, own electricity. It working appropriately is just paramount to our survival. We have that blood flow through the heart that I asked you guys to review and remember. If you need it again, here you go. Review of the electrical system. So we've got the sinoatrial node and the atrioventricular node. SA node is that main one. The pacemaker keeps a good rhythm going. We've got a backup AV node if it doesn't work. And then the Purkinje fibers are just the pathway of the electricity, the wires, if you will. So when the electricity is working, this is what it looks like, right? And so technically 2 contractions of the muscle equal 1 pulse. We've got the aorta and then the ventricles. And not all chest pain is the same. So some of the 6 life-threatening causes of cardiac chest pain, we've got the classic myocardial infarction, the MI, also known as a heart attack. We've got unstable angina pectoris. An aortic dissection. Cardiac tamponade, a PE, which we already talked about, pulmonary embolism, and a tension pneumothorax. So we've talked about some of these already, right? And this is all about chest pain. So these are pretty much the big things that we're going to be assessing for when somebody says, I have chest pain. And through that assessment, we should be able to make the determination, respiratory, cardiac, trauma, essentially. Those are the things that it could be. So a myocardial infarction would be in this picture right here, when one of those arteries to the heart is blocked and the blood cannot get through it. And so therefore that section of the heart tissue begins to die and heart tissue cannot regenerate itself. So any cell that dies in the heart is just dead. So it can be a partial block, which usually causes angina, or it can be a full block, which is when we'd say this is a myocardial infarction. Cardiac tamponade is this image down here. So similar to the lungs, the heart has a pleural lining, essentially. It's got a lining around it. And if that begins to fill with fluid or blood, that's when we call it a cardiac tamponade. It's essentially pressure building up around the heart. It's drowning. It doesn't have enough room to squeeze and contract. Oh, I forgot about one. So this isn't necessarily cardiac, but it's an esophageal rupture. This happens when somebody vomits a whole bunch, and it can lead to rupturing of the esophagus, which can be really painful and really bad. So the main thing that we're concerned about when we're talking about chest pain is, do we think that the heart is experiencing ischemia? Is the heart getting the oxygen that it needs? If it's not, that means ischemia is happening. There is a blockage. The heart muscle is not getting the oxygen that it needs, and therefore it is dying. It is suffocating. Heart tissue does not regenerate, like I just said. So once it's dead, it's dead. So essentially, every minute of what we assess to be ischemic heart pain is tissue death. And the more that happens, the more likely that patient is to just suddenly drop dead. Some of the reasons that this happens is atherosclerosis. Oh my gosh, atherosclerosis. There we go. It's a buildup of just like plaque, cholesterol inside our vessels. So lifetime of bad diet can tend to do this, and it obstructs and it impedes that blood flow. So as you can see here, this inside, right, it's getting more clogged with all of that gunk. So the blood cells have less places to go, fewer or less of a diameter to fit through. This is the main cause, high cholesterol. If it's not treated, right, it'll slowly get worse. This person might start to develop what we call angina. They have periods of transient chest pain, but that's a warning sign. It'll tell us that eventually that artery is going to get blocked, and therefore they will have a heart attack. So here's another case for you. So 57-year-old man who calls 911 after he developed mid-sternal chest pressure with mild sweating when he was raking leaves. He has no history of previous symptoms. He was pain-free after about 5 minutes of rest, and he has a completely normal initial assessment and does not want to go to the hospital. Does he need to go to the hospital?
No.
Yes, eventually. I mean, we should take him now and suggest he goes now, but he has blockage of some kind.
Okay, I love it when that happens where someone says no and yes at the same time. So what I would say here is that he doesn't emergently need to go to the hospital. I would not transport him lights and sirens, but because this has never happened to him before and he's having substernal chest pressure, it's always better to get checked out. However, if he says absolutely not, no way, I'm going to sign your paper, I'll check in with my PCP tomorrow, we should try to get him to go to the hospital. But if he's conscious alert oriented ×3, we can't make him go. I would recommend that he goes though. So what that was kind of just describing there is a pretty common condition called angina pectoris, or angina, whatever you want to say, whatever's more comfortable for you. What this is when there is a demand of the heart of oxygen that it can't meet, essentially. Now, this isn't true tissue death because the heart is still getting oxygen, but it's to the point where it's not enough for it to feel right. So this is usually a transient thing. And we kind of break it up into two different sections. There is stable angina and there's unstable angina. So stable would be similar to that guy that we talked about earlier. So he had the chest pain, he sat down, and after about 5 minutes, it went away. If the pain is relieved by the standard treatment or rest, that's when we'd call it stable. So a lot of people live every day with stable angina. They're prescribed nitroglycerin because they have a little bit of chest pain. They take a nitro and it opens up their vessels and it stops that chest pain in the same way that we can give nitro. When we would start to say that this is unstable or dangerous is when the pain is not relieved by nitro or rest. And when it comes out of an abnormal situation. So a lot of people who have angina will get the pain after exerting themselves. So walking upstairs, lifting something heavy, doing garden work. And that would be kind of stable, right? They doing something that exerts their heart. It starts to hurt. They take a rest. It goes away. Pretty stable. When it's not stable is when they're not doing anything strenuous and that chest pain comes around. So somebody's sitting down in their lazy boy watching soaps, right? and their chest pain starts to hurt. It doesn't go away when they take a nitro. They were already resting. It shouldn't have happened, right? It could get better after a little bit, but that's a pretty good indication that this is not stable, and they're likely going to have a heart attack pretty soon. It's one of those, it's a really big warning sign. All right, let's talk about another one. 72-year-old woman with known coronary artery disease. She typically gets angina with exertion and usually takes 1 nitro to make her symptoms resolve. She calls 911 after getting chest pain while watching TV, which finally resolved 40 minutes after she took 4 nitro. She says she feels better and doesn't want to go to the hospital, but she's tired. She just wants to go to sleep.
Transporter.
Yeah, sorry, lady, you're not going to sleep. This is really bad. And even if she doesn't want transport, we should do our best to convince her to go, right? She had chest pain for 40 minutes after 4 nitro. That is way more nitro than she should be taking. We can't even give that much, right? That's a big, big warning sign. More commonly associated here, that type would be with a heart attack, a myocardial infarction. That word infarction just means blockage, essentially, and myocardial just means the heart. So this is a complete blockage of one of those coronary arteries, and the oxygen cannot get to those tissues, and cardiac cells cannot regenerate. There are some ways to mitigate the amount of damage if we get them to the hospital as soon as possible with thrombolytic drugs or surgery. But essentially, for every second, for every minute that a patient that we suspect has cardiac chest pain or a heart attack, time equals myocardium. Every single second, more cells in their heart are dying. And there's only going to be so many of those cells that can die before that person dies, before that heart cannot beat anymore. So cardiac ischemia is going to be when one of these fancy dancy heart-owned blood supply vessels gets blocked. Now, the type of heart attack or the area of which these vessels is blocked is going to make a determination on what we can assess the patient outcome to be, right? If it's just one of these little tiny ones, less of that tissue is dying. So they could probably survive that with quick treatment and surgery. But what if like one of these big ones was blocked right here? All of that section is going to be losing oxygen, and that big portion of the heart is going to die. So when a medic is reading an EKG, what that's actually giving them a picture of is essentially a 360-degree view of the heart working. And so those lines, the measure of electricity, can actually tell them where on the heart 360 degrees is not working well enough. So once you get down to it and you learn how to do that, after doing it, you can say essentially, this is super dumbed down, but the anterior left lower portion of the heart is having an infarct. That's bad, right? But they know exactly where it is based off of those, the sheet that you print out. Our purposes though, we'll put it on, we'll see what the EKG says, and we'll send it to the hospital. And if it says STEMI or MI, go faster. So how can we tell if somebody who's having angina or somebody's having a heart attack? How can we tell?
If it occurred at rest and doesn't get better with rest.
Okay, yeah, that's one way, potentially.
If symptoms don't improve with giving nitro.
Okay.
Shortness of breath.
Yeah, potentially. All these are really great answers, guys. But you're essentially describing the signs and symptoms of angina or a heart attack. It's a trick question. We cannot make the determination of if they're having angina or a full-blown heart attack. As basic EMTs, we cannot. Monitors can miss it. Even if we put on the EKG and it prints us out a reading, it might not be accurate. So for our purposes as basic EMTs, if somebody is having substernal chest pain that we can consider to be cardiac in nature, even if this has happened to them before, and they say it's angina, we have to treat them as if they're having a heart attack. Because if we're like, oh, you know what, you were exerting yourself for a little bit, you took a nitro, it's feeling a little bit better, but you're still having some chest pain, I'd say you just sit at home, relax a little bit. We've got other stuff to do. We leave, they have a heart attack, they die, you're at fault, right? We as basic EMTs do not have the equipment or the training to say you are definitely having angina or you are definitely having a heart attack. We need to treat it as acute coronary syndrome. Time equals myocardium. Anytime there's chest pain that we can assess to be cardiac, we cannot make sure, or we cannot be sure whether or not that heart tissue is dying or it's just a little bit upset. We need to get them to go to the hospital, or at least highly advocate that they do if they're very resistant to it. There are ways that we can say, you know what, I think this is leaning towards this, but we cannot make that determination. We always want to play it safe. Bring them to the hospital. All right, what's this one? So a 68-year-old woman with a history of hypertension, COPD, and CAD, who takes a fluid pill every day. She's been more fatigued over the past 2 weeks and gets more easily winded. She calls 911 after suddenly having severe respiratory distress with mild chest pressure. Our initial assessment finds an anxious patient sitting upright with profuse sweating, accessory muscle use, and decreased breath sounds in both lung bases with expiratory wheezes. Vital signs, pulse of 125, respiratory rate 34, blood pressure 205 over 102. What do we think's going on?
Congestive heart failure.
Yeah, that's a pretty good guess. Why'd you say that?
I think the wheezing or decreased breath sounds in both lungs, the history of the fluid in her lungs, or the fluid pills needed. I'd say probably be what I would think.
Yeah, that's a pretty good guess. Anybody else have another differential diagnosis? Congestive heart failure. So CHF is another very common condition that we'll run into. What this is essentially the heart is losing its ability to keep up the amount of blood it needs to push out every beat. So we call that a loss in stroke volume. And so because the heart can't push out enough blood, we're going to see some other signs and symptoms leading to this kind of domino effect. But we also have to keep in mind, and this is one of the reasons why I wanted you to learn the pathway through the heart, because this is going to give you a lot of information about congestive heart failure. We can use the signs and symptoms that they are demonstrating to discern which side of the heart is failing. So if somebody's right side of their heart is failing, we're going to see different signs and symptoms than if the left side of their heart was failing. It's the same issue, but it's a different portion of the heart will give us different signs and symptoms. Causes of this are just going to be, if they had a heart attack or if they have angina, their heart tissue is going to die at little bits at a time. And so therefore it's just going to be essentially getting weaker. If they don't take their medications when they really need it, pneumonia can have a cause in this, and then also just really poor diet. If the heart gets too big, it's not able to squeeze as much. So if the right side of the heart is failing, we tend to see fluid backup in the body. We tend to see it in the wrists, the legs, the ankles. But why?
The vena cava can't deliver blood into the heart?
Exactly. If those two vessels that bring the deoxygenated blood back to the heart, if the heart can't accept all of that, that right side of it is failing, it's not pumping enough down, we're going to see a backup of that fluid into the body because it's not getting into the heart yet. It's just all kind of like a traffic jam right there, and that fluid is going to back up. So it tends to follow gravity. So we're going to see it go down to the lowest parts. So if somebody's sitting down, it'll pool in like their thighs, but if they're standing for most of their life, it'll go right to their legs. So we see something like this, and we can assess it. It's called pitting edema. So if you take your finger and you push on the swollen calves and it leaves an indent like that, that's called pitting edema. That tells us that they likely have a lot of fluid building up in their legs. Now, guys, I'll be honest with you. this is gross. You will see patients like this, and late stage, all these sores and boils and stuff really build up, and can get really gross. I will tell you a story. So we went to this woman having difficulty breathing. Obviously, I'd been to her before, and it was obviously CHF. We had done this before. Her calves, she was an overweight lady, but her calves, I've never seen bigger calves. They looked, and they were wrapped in ace bandages. So they looked like, like a Christmas ham. Both sides, seriously, massive. And she couldn't walk very well by herself. And so we were getting her onto the stretcher. We got her to stand and then pivot and sit down, but she couldn't lift her legs up when she was weak and they were really heavy. So I had gloves on, thank God. And I went to go down just to help her lift her legs up onto the stretcher. So when my hands felt the skin at the back of her calves and I started pulling to lift, there was probably about 2 good inches of movement where I compressed before I actually started to lift her legs up. So I moved it over, I put her down, and when I pulled my hands away, they were literally dripping, as if I had just scooped up water and let it fall through my hands. Because the reason she had wrapped them up is because she had so many open sores that the fluid in her legs were leaking out. So when I looked at my hands, it was literally running through my fingers.
I saw that's pretty often at the rehab.
Yeah, this happens quite frequently. When the heart starts to fail, it starts to back up. A lot of people have CHF. It can get really bad. And this is so uncomfortable for these patients too. Like, I can't even imagine. But I think back to that all the time where I'm just like, okay, why aren't her legs moving up? And then I was like, all right, we get there. And then I pulled away and it was literally like, okay. Hey, you guys get her out to the ambulance. I'll be right there. So yeah, pitting edema, very good assessment. Tells you that they have a lot of fluid. So then with left-sided heart failure, it backs up to the lungs, because on the left side of the heart, right, they're receiving that blood flow from the lungs back to the heart. So if that side is failing, it can't accept enough fluid back in to send it out to the body. So it backs up to the lungs. So that's when we're going to see that pulmonary edema. So patients with heart failure of the right-sided variety are going to exhibit less so difficulty breathing signs and symptoms, more so swelling and other kind of related chest pain issues. Whereas patients with left-sided heart failure, they're going to have really difficult time breathing. And it's going to be different from like that COPD type of breathing, although most of the time, a lot of patients have CHF and COPD together. But we're going to see a lot more wet lung sounds with a left-sided heart failure. Hypertensive emergencies. Now, blood pressure fluctuates very quickly all the time. It's constantly moving up and down for everybody. So having a high blood pressure for 10 minutes isn't going to be a major issue, but very long-term chronic high blood pressure is. And if it's at a certain level to a certain height, the risks in that short period of time increase greatly. So when we are exercising or if we're exerting ourselves, our blood pressure naturally goes up. But if you're not exerting yourself and your blood pressure is higher than 180, you just have the chance of something bad happening. You can have a retina detach. Essentially, if the blood pressure is too high in your eyes, it can rupture, it can detach from that, and you can just go blind really quickly, just from having a hypertensive emergency. You're at risk for heart attacks, you're at risk of stroke, because essentially, the way that I think about blood pressure is if you picture like the 7 dwarves from Snow White, right? Every time your heart beats, the 7 dwarves are walking through your vessels. So if your blood pressure is normal, they're just like checking how good the walls are holding up, right? They're just kind of like knocking on it, making sure there's no weak spots, just going around. And that's normal for everybody, right? Our pulse is exerting force and pressure on all of our vessels. If our blood pressure is really high, we give those dwarves sledgehammers. And instead of just like tapping on the walls, they're hitting it. Every single pulse, they're hitting the walls of your vessels. Now, for a little bit, that's fine. But if they're constantly hitting your walls of your vessels with sledgehammers, eventually one's going to pop and one's going to break, and you're going to start bleeding internally. Usually that happens in the smaller fine vessels in our brain in our eyes, in our heart. So that's why high blood pressure is really bad. We consider it a hypertensive emergency if it's above 180 systolic. And the signs and symptoms people will usually describe with this is like blurred vision, shortness of breath, really bad headache, vertigo, which is like dizziness, tinnitus, ringing in your ears, and then epistaxis is just the fancy word for nosebleed. So because it goes, if high blood pressure is affecting those little vessels, we have a lot of little vessels in our nose. A lot of times we can see patients with nosebleeds with severe hypertension. And these patients are really interesting because like you put the blood pressure cuff on, and after taking enough, you always like pump up to like a certain number because no blood pressure gets that high and you're like all set going. With these, you put on the stethoscope, you pump it up to like 200. You can still hear the pulse. So you pump it up to like 220. You can still hear the pulse. So you're like, oh boy, keep pumping. And then you get really high up. Like I think the highest blood pressure I've ever taken is 280 systolic. Really bad. And the guy was just like bright red in the face. He's like, I've got ringing in my ears and my head hurts. And I'm like, yeah, dude, you're really close to having a stroke. We should get you to the hospital. Not much we can do for this treatment. We are not going to give nitro for this. Say that again. We are not going to give nitro for high blood pressure. That's not why we give it. Although it would probably work, it's not why we give it. And you would be breaching your scope of practice. Other than that, transport them to the hospital, check their blood pressure every couple minutes, give them oxygen. Aortic aneurysm. This one is just scary. So the aorta, right? The descending aorta is the biggest, most high pressure vessel we have in our body. And if it ruptures or has an aneurysm, somebody can bleed out in less than 2 minutes internally, very quickly. And it is very hard to fix this ruptured artery. So the signs that we can assess for this is a severe and rapid onset of either abdominal or back pain. And this is one of the only times that somebody without prompting will describe a pain as tearing. It's a rare sensation for us to have, an internal tearing sensation, but like 9 times out of 10, somebody having an aortic aneurysm will say, oh man, it's like a tearing pain. And so if you hear that in regards to sudden onset abdominal or back pain, that's a pretty good sign that you should get them to the hospital ASAP just for an x-ray to make sure. Because if it ruptures or if something happens, they will die in very quickly. So what this is it's either a dissection is when the internal layer of a vessel kind of blips off a little bit and there's still some wall holding it, but it's a thinner vessel wall. Whereas an aneurysm is when that rupture, that dissection kind of breaks and that fluid will come out. One's more like ripping of the cell or the vessel wall, and the other one is kind of a malformation of it, a section, like, why am I blanking on the word? Just kind of grows off of it. And both of those can rupture and start bleeding really badly. You might, depending on the location of this, feel a pulsating mass on an abdominal assessment. It would feel really strongly like a pulse in the upper or lower abdomen, but it can also be anywhere from here essentially down. And so you might not be able to feel that aneurysm if it's below the ribs. And if you do, we don't want to push on it. So this is how I felt a lot of the time. But now that we've got all this information, we can do a little bit of putting it all together. So our treatment of cardiac chest pain, it's all going to depend on a good assessment and a good history taking. Physical assessments are key, and then vital signs are, vital. We can monitor their cardiac health, so we can use an EKG. We can't read what it says, but we can have the monitor give us a printout, and we can say what's on top of there. And we can give some medications. So here's just what the placement of an EKG looks like. Now, it's also called a 12-lead electrocardiogram. The reason it's EKG and not ECG is just a matter of language. EKG is electrocardiogram in German. And that's the people who developed the 12 lead. And we in America, we do C. So ECG or EKG, it's the same thing. Whatever you want to use, it's up to you. I like EKG. I think it sounds better. It's 12 leads, but it's only 10 stickers. So we're going to place 10 stickers on our patient with leads to them. And one of them or two of them just give us 2 readings. So we're going to go over this in lab. We'll do some stickies on a mannequin. But essentially what we do is we place the ones labeled V1 and V2 on the 4th intercostal space. We don't want these to be over the bones of the ribs because it will impede their ability to read the heart. So we want to find on our ribs like the places that are the intercostal spaces. So 1 and 2 on the 4th space, 3 and 4 kind of just down around there. We're trying to make a loop around the heart. So because the heart's right here, we're trying to get an image of all different sides of it. So we're trying to loop around. The mid-clavicular line, right? That's a good landmark for V4 right here, this orange one. And then V5 is kind of at the side here. And then the mid-axillary line at the armpit for V6. And then we're going to put different leads on the arms and the legs. They can also go on the top of the sternum here and then down at the abdomen. But they will also go on the back of the arms on the fleshy spot and then the back of the calves. So once we have all these on, we get a readout like this. So each one of these printouts is the same heart rhythm, but it's from a different angle. It's from a different picture of the heart, one of those different leads. So when somebody who's trained looks at this, they can say, okay, I'm reading it. I see these abnormalities in here. And so therefore that section of the heart is having issue. This is what we need to do for it.
Kevin,
Yeah.
is that color coding for the leads standard?
No, not completely standard. They're each kind of monitor or like EKG manufacturer has different
yeah.
ones.
Okay, thanks.
But it's all the same placement. So it'll all be V1, V2, V3, V4, V5, V6, and then the 4 lead. It all goes in the same order standard, but whatever color they use is up to them. Other things about taking EKGs, the patient really should be not moving around a lot. Even if you're in the back of the ambulance, like if you need to take a good picture of the heart, we should have the ambulance stop. It's amazing. Like you throw an EKG on, no one's moving. It's perfectly crisp lines. As soon as that ambulance starts going, it's just like there's so much artifact that the EKG can't be read essentially. So moving, we want to have them take this EKG when we're not moving. And the placement is going to play a big part in how clear those lines are. So when all else fails, we're not able to help them. Not able to help them keep their microphone standing. When we're not able to help them, even if it's emergency, there are some things that they can do. So we're likely going to see these patients after these conditions. But the big ones here are coronary artery bypass graft, or a CABG. Don't make the mistake I did. And I learned what a coronary artery bypass graft was, but I didn't learn that it was called a CABG. So I went to pick up somebody at Fanny Allen from the rehab center, and the nurse said to me, essentially handed me his paperwork, and she's like, he had CABG. And I was like, okay, but why'd you call 911? She's like, well, he had CABG, and that's a big reason. I'm like, is he allergic to CABG? And then one of my crew members was like, Kevin, coronary artery bypass graft. And I was like, you're absolutely right. He did have a CABG. Oh, yes. Let's go to the hospital right now. Let's leave as soon as we can, right? So that's essentially when they bypass part of the coronary artery by grafting. You can see where I got that done. So somebody had a blockage of the coronary artery, one of those things that goes to the heart. So they essentially connect some vessel around the blockage to redistribute the blood. Angioplasty, essentially heart surgery, and then a cardiac pacemaker, which is an implantable device that can make the heart contract on its own. It can help pick up slack where the SA node or the AV node fall off. Other assisted devices are an implantable defibrillator. So somebody actually wears, similar to a pacemaker, a thing that will shock them if it registers they go into a into a shockable rhythm. Essentially, they go into cardiac arrest and it will shock them back. Sometimes they can have external defibrillator vests, but nowadays, most of the time, it's an internal one. And then an LVAD, we're not going to talk a whole bunch about these. These are just crazy. It's essentially a device that is an external heart. So it's like gets rid of the need for the heart to pump. There's a tube at the top of the heart that brings the blood that gets there to the lungs, and then there's a tube outside that brings it out. It actually then it enters a physical pump after it gets oxygenated, and that's what gets them to the rest of their body. So they wear their heart outside. So you can't get a blood pressure because there's no pulse, and you can't assess a pulse because there's not really a pulse. So this is a weird device. Luckily, these are pretty rare. And if somebody who has one of these moves into your service area, pretty sure they like have to communicate with ambulance services so that you would know. Somebody briefly moved into Colchester when I was working there. And so we had extra trainings to learn how to help out with an LVAD, but I have never actually worked with one. I think it's just crazy. You literally have no blood pressure, no pulse, and you wear your heart outside your body. It's intense. Of course, the video I wanted to show you has been removed. It was a clip from an Australian beach rescue show, reality, but they work an actual cardiac arrest on it. So it was really interesting. I think it's called Bindi or Bondi Rescue. You might be able to find the clip on YouTube, but essentially a guy was swimming, came out, was really red, flushed, and sweating, was saying he's having chest pain and difficulty breathing. After about 15 minutes of talking with the first responders, he went into cardiac arrest. They do CPR on him. I don't remember the outcome because I only really showed them to the point where he got to the ambulance, but apparently he lived. Chris, give me a thumbs up, so good for him. But it actually showed real compressions in it, because the next thing we're going to talk about is cardiac arrest. So essentially, cardiac arrest is when the heart is not beating enough to sustain life. So that could mean a couple different things. That could mean that the heart has no electrical activity going through it at all, or the electrical activity going through it is weird, wonky, or it's just not enough. So technically anybody, somebody who's in cardiac arrest, their heart muscle can still be alive, but the electricity is all wonky. And so they get the same treatment as anybody that we'd consider to be in cardiac arrest. They're going to get compressions. They're going to get the defibrillator or an AED. So what the AED does is through contact with the skin, it measures the electrical activity going through, and it can determine whether or not it needs to be shocked. There are two shockable rhythms, which we'll talk about. But essentially, if somebody is unresponsive, if they have no pulse and they're not breathing, compressions need to be started, and an AED should get there as soon as possible. We in Vermont are practicing what we call high performance CPR, which is different than what the AHA and Red Cross are officially certifying people in. And it's actually worked wonders. So roughly, what was it? Less than 10% of patients who went into a cardiac arrest, who got 30:2 compression to ventilation ratio, so AHA standard, less than 10% of those patients survived and went on to live another part of their life. They left the hospital after this cardiac arrest. With high performance CPR, that number has jumped to around 40% of people are leaving the hospital and surviving. So it's working really well. So that's what we're doing. And all the difference is focus on compressions. We're not really wasting time bagging them until we get a certain level of people there that it can be managed. Our first priorities are continuous, good quality compressions and an AED. That's essentially it. Cardiac arrest. That's the only indication. The reason I put this in here is that there are plenty of providers, I've heard providers say this, where they're like, oh, you know, you're having really bad chest pain and your vital signs are declining. You're kind of nervous. I took an EKG, it says myocardial infarction. Hey, don't get anxious or anything, but I'm going to put these pads on your chest just in case. Right? No. A potential cardiac arrest is not indicative to put AED pads on. Cardiac arrest is. Okay. if you put it on somebody who says, just in case you die, you might increase the chances that they die. So AED advantages is that ALS providers don't need to be on scene. Before, defibrillators were all manual. They had to be manually interpreted rhythms, and then a doctor or medic had to say, okay, shock. But this device, you slap it on, you turn it on, and it essentially tells you everything you need to do in very slow, concise words. So it's mainly for use of lay people, and you'll see them all over the place now. And I'm pretty sure majority of public buildings, it's legally required for an AED to be in there. So it's always good. Yeah, go ahead.
So I have a question about, I know our rig has a standard AED, the green style, but it also has the Zoll, which you can also shock people. Are we allowed to use the shock portion on the Zoll or just the AED?
Yes, you can use the shock portion on the Zoll as long as it is set to AED mode.
Okay.
So that's, yes. So AED advantages are that lay people can use them. We also can use them. Like if you are on scene somewhere, not well, like if you're off duty and someone needs an AED, use it. But if you're on the ambulance and you have a Zoll, you can turn it to AED mode where it's not like you have to tell it to shock, but it tells you when it needs to. So yeah, we can use these. These ones are just publicly available. So you might show up to a cardiac arrest call where somebody's been using one of these and you need to know how to use it. Essentially, you just hit on, set it up correctly, and it will go. So the two shockable rhythms that it's going to look for is ventricular fibrillation, also known as VF, or ventricular tachycardia, also known as VT. So VF, ventricular fibrillation, the heart kind of like jiggles around. It's just like a bag of worms. The electrical activity isn't working very well. It's misfiring. Whereas ventricular tachycardia is that the heart is beating essentially too fast for any oxygen any blood to get in there. So it's opening and closing so fast that blood can't make it in to get circulated. So VF will look like this on a monitor, even though we can't determine it. It'll look way wonky and wavy. Whereas VT will just look like really, really fast heartbeats. So this is what it kind of looks like. This is a real heart in VF. It looks like a bag of worms. It's just like jiggling. Whereas ventricular tachycardia is that the ventricles are beating too fast to allow any oxygen or any blood in. And both of these people will be unresponsive, have no pulse, be not breathing, and they should get CPR and an AED. It's not like the movies. It's not like Grey's Anatomy. I'm not going to get started again. But when, in all of those movies, they're like, they're flatlining, spark them, right? And then they wake up and they're like, oh my gosh, marry me, right? Like that's how it happens all the time. If somebody's in asystole, they have a flat line, that means there is no electrical activity happening in their heart, and a shock of electricity likely will not fix it. So we do not shock asystole. A AED will not shock asystole. It will only tell you to shock if one of these two things is happening. Okay, so it's actually better if somebody's heart is in one of these conditions, because that means it can be corrected by electricity and compressions. If it's asystole, that's bad news. Asystole is the only heart rhythm that we can determine. So there you go. You just gained another skill. You guys can determine when a line is flat.
Kevin, what about people that have like internal defibrillators that are malfunctioning and like they keep shocking the patient? And if you have them hooked up, and it shows that it's shocking them, is your AED going to try to like get them back into normal rhythm?
Yeah. If the AED registers an abnormal rhythm, it won't automatically shock them. You have to hit the button to say shock. But yeah, it'll say shock advised.
And if you know that, like, I guess we wouldn't be able to determine like whether their internal defibrillator is malfunctioning or not, but like what would you do?
That's a great question. I hadn't thought of that. I don't know. That's something I can look into. It's just like what to do if somebody is unresponsive in cardiac arrest while you assess that they're having an internal pace or defibrillation. The whole point of them is that they should work. And I'm pretty sure if they don't work, they're going to stop shocking. But yeah, if one's malfunctioning, I have no idea. That's a really great question. Compressions.
Have you ever watched like Night Watch?
Yes.
Okay, so I only ask because there was a patient on there that had an internal defibrillator that was actually like he was alert oriented walking around and it was shocking him and he was like, I don't know why it's shocking me. So I just didn't know like if you know you brought him into the rig, hooked him up and like it was registering like, hey, it's shocking you, but like nothing's wrong. Like if it would then say
The
like
difference
let's try to
is
shock you back.
if he's conscious, I'm not going to put an AED on him. It's
Right.
if he's conscious and it's shocking him, it's obviously malfunction because he wouldn't be able to withstand or be alive with one of those cardiac rhythms.
Right.
So that's one of those things. If he was unconscious and he was randomly getting shocked while we were doing compressions and we hadn't set it up, that would be really concerning. I don't know what we'd do in that situation. I'd call medical control.
Okay.
Yeah. Okay. So I'm going to try to fit this in the last 15 minutes. We, as EMTs, if somebody is in cardiac arrest, we need to give it to them. So if somebody is unresponsive, they don't have a pulse, and they're not breathing, we begin CPR as soon as possible. That means as soon as you assess it, tell whoever's closest to the chest to start doing good compressions. And we want to get an AED on as soon as we can. However, there are times where doing CPR on somebody who is unresponsive, not breathing, and does not have a pulse will not work no matter how well you do it. And in Vermont, we can determine not to start CPR on somebody based on a couple of things. If we register one of these factors of death, we can declare that person dead and we do not need to begin CPR. So if somebody is decomposing, they've got mushrooms growing out of them, they've been dead long enough where you can smell it, they are decomposing, they have been dead for a while. If they do not have a head, or there is exposed brain matter, or they have essentially decapitation, no matter how much you push on that heart, you're not going to grow their head back, you're not going to reconnect their brain. Incineration, if they are burnt to a crisp, you're not going to get them back. Rigor mortis, which is one of the first signs of death we'll see, or factors of death we'll see, is when the muscles become rigid. So a quick physical exam of somebody you want to do CPR on will benefit you, because if for some reason you lifted their arm and it stays right up, or their hand is clenched and you try to open their hand and you can't and they have no pulse, that means they are too gone. You will not revive them. So any sign of rigor mortis, factor of death, do not start CPR. And then lividity. This is a sign of blood pooling. So if somebody's been laying down on the ground and they've been dead for a while, or even sitting in the chair, the lowest point of gravity, you will see blackish purple pooling. It looks like a big, big bruise, but it's essentially blood just pooling in that area. So before you start CPR on somebody, do a quick check of where the lowest part of their gravity was, and you'll see. It can be a little bit like little bruising, or it can be complete purple. We went to this guy who it was a welfare check. We know he had asthma. It was Christmas Eve. We got let into the apartment. We found him laying face down in his living room. And I just went to roll him to assess, to get him on his back. And it was literally stiff as a board. He just completely rolled, was flat and purple. He had been on the ground for probably a day or two. So pretty easy decision right there. We're not going to start CPR, call the medical examiner. We're done. Now, the thing about Vermont is that they've made the determination, and it is going to be changing, I think, in those 2022 protocols. So keep your ears out. But as of now, with our current protocols, if a patient has blunt or penetrating trauma that we think caused their cardiac arrest, we will not begin CPR. Okay, so if somebody is ejected from a vehicle, you get there and they are massively damaged, you check for a pulse, they have none, they are not breathing, we do not begin CPR. If they were shot, if they were stabbed, if they were hit by something, they are beat to death, if they are dead and it's due to a blunt or penetrating trauma, we should not begin CPR. Now, somebody dead in the presence of a traumatic situation does not mean the same thing. There was a story at St. Mike's where a car was caught on video barreling down Colchester Ave into the Winooski Circle. It like got air, crashed right into the circle. Rescue shows up. There's a guy who is dead behind the driver's seat. No pulse, no breathing. But he did not have any signs of damage to him that would lead them to think he died due to trauma. They started CPR. Turns out he had a medical emergency at the top of the hill. His car coasted down and he crashed. The crash did not kill him. It was the medical thing that happened. They got him back. And as far as I know, he brings like apples by the station still sometimes. Okay, so an assessment is really important too. We're not going to say blunt or penetrating trauma. He's in a car accident, he's dead, right? No, it needs to be the blunt or penetrating trauma that put him into cardiac arrest. So say that CPR is indicated. They don't have any of those factors of death, pulseless, apneic. Put on your BSI, call ALS, and begin CPR. For us, chest compressions at a rate of around 100 to 120 beats per minute, going at least 2/3 the depth of the chest, and a quick attachment of an AED. With high performance CPR, we're just going to worry about compressions. Every 2 minutes, we're going to switch who's doing compressions to get the best possible compressions constantly. When we apply the AED.
I have a question about, so out here in the islands, when we have CPR in progress, when we call like for ALS, they send out fire as well to make a chain for CPR. Is that standard in Vermont or no?
I don't know if it's standard in Vermont, but it's always a good idea. If you have smaller amounts of crew, but you need bodies to do CPR, get as many firefighters, as many other people as you can, because doing 2 minutes of good CPR is really hard. So the more people you have to swap in and out of the chest, that's great.
Cool.
Yep. So AEDs have to go on the bare chest. If you do not put them on the bare chest, they will not work. We want to put them on the left flank and the right chest. We're essentially creating a pathway for the electricity to go through the heart. And we're going to put them on. We'll plug them into the AED. We'll hit on, and then it will start to analyze. Now, AEDs can be kind of dangerous. What areas would you think should we not use an AED?
Near water.
Connor says, well, near water, it could be kind of nice to do cardiac, like a CPR, like on the side of the lake with a nice view. But if they're in water, that's the difference. By water, we want to be cautious. So if they're in a puddle, move them. If they've got a whole bunch of liquid on their chest, dry them off and put it down. If we're standing in water and we shock somebody who's in that water, we will get the same amount of shock. If their chest is super wet and we put the pads on, the electricity is not going to go through them. It's going to go across them, and they're not going to get an actual shock. Connor also says no metal. That's absolutely right. What about snow? We're in Vermont. Can we shock on snow?
I would say no, because it's water. It's frozen water.
Yes, you
don't
can.
throw like a blanket.
Snow is non-conductive, I think, right?
Yep, you can absolutely shock on snow.
Cool.
It's not conductive like water is. That crystalline structure of it does not conduct. I have shocked people on snow. I am still standing. That was supposed to be metal. There we go. But we also want to make sure that they don't have any medication patches. If somebody is in cardiac arrest, they're not producing body heat, and so they likely wouldn't melt that snow fast enough. It's a good thought, though. If it begins to melt for some reason, we'd move them. But for the most part, good cold snow, not conductive. Somebody has like a medication patch on them, especially in the area where we would put those EKG patches or AED patches. We want to remove it with a gloved hand and then wipe away residue. Some patches, medications, specifically nitroglycerin, can be explosive if you shock them. So that could be bad. And we also want to do it with a gloved hand because we don't want to accidentally get some transdermal like fentanyl on our fingers before we're supposed to work a cardiac arrest.
And would that be the same for underwires as well?
What?
Would that be the same for underwires for burning on them, from what I've heard?
Yeah, so we should remove all metal things on them as well. Yeah. So if they're wearing clothes with metal in them, like a lot of bras have metal lining, they've got conductive jewelry. We want to stay away from those things. I'm not going to tell you to spend the time to remove somebody's nipple piercings in order to do good cardiac arrest. Just remember that they could get hot, temperature wise. The other thing that we want to avoid are those internal pacemakers or defibrillators. A lot of times they are put on the left side of the chest as to not interfere where the patch is. But if they are on the right side, we want to move the patch down. If we were to shock directly over these things, they could also explode. And you would look like that. Now, another one of the things that I wanted to talk to you guys about, please excuse me, I did have to put a picture of myself in this presentation, but we also don't want to put patches on people who are super hairy. That is me, I know, don't worry. But seen it happen where they put patches on somebody who was very hairy. The patches were probably about like a millimeter elevated off the chest, but they thought it was good. They hit shock, and a plume of smoke and flame just coursed across the guy's chest and melted all of the hair on his chest. So not having contact to the skin is very bad. If somebody is very hairy, you need to put the patches on. Most of the AEDs or monitors come with a little razor, shave it off. Yep, absolutely right. If for some reason you don't have one of those, but you have 2 sets of pads, put the first set down, rip it off, and then put the second set on. Okay, I know it sounds kind of rough, but I would much rather wake up looking like Steve Carell than not wake up at all, right? I'd much rather have patches in my chest hair than not wake up. So if you need to get the patches on their chest, you don't have a razor, get that hair off their chest. Cool. Now, if we're going to use the AED, we cannot be touching the patient because one, if it's analyzing and we are touching them, it will register our heart rhythm through our skin, and it will give us a false reading on whether or not they need to be shocked. And if we are touching them while somebody shocks, then we will receive that same shock. And that's bad. So once you hit go, it will analyze. It will tell you shock advised or no shock advised. If shock is advised, clear the patient, hit the shock button, and then begin CPR again. And if no shock advised, just continue CPR. So if you're going to continue no shock, continue CPR if there is no shock, and you're going to do this every 2 minutes, essentially, until you have a determination on one, you're going to transport them to the hospital and continue CPR, or if you can determine them dead on scene. So you're going to stay on scene doing CPR until you've delivered 3 total shocks or 3 consecutive no shocks with 2 minutes of CPR in between. So this could mean quite a bit, right? If you have 1 shock, 1 no shock, 1 no shock, 1 shock, 1 no shock, 1 no shock, 1 shock, right? Every 2 minutes, you've done CPR for a long time on scene, and only after that 3rd shock would you transport. But it could also just be 3 consecutive no shocks in a row. That would give you enough to say, okay, potentially we're going to call it. Yes, Jose, we do pronounce patients dead if they meet the criteria. So that's what I'm getting at here. So if you deliver a shock at all, we're going to transport them to the hospital. We're going to work our cardiac arrest all the way there. But if we do CPR for 20 minutes and we get 3 consecutive no shocks, we can call it. Or we're going to do this until a pulse returns. That's the best possible outcome. So if you give 1 shock at all, you're going to transport that patient. But if you give no shocks and 3 consecutive in a row, after 20 minutes, you can call med control and you can talk about TOR, termination of resuscitation. So after 10 cycles, 20 minutes of cardiac arrest with no shocks advised and no spontaneous return of circulation, after we call med control, we can have a discussion with them and say, this is what we've done. We're going, like, do you feel comfortable of us calling it? And most of the time they will say yes. And so that would allow us to say time of death, whatever time it was, and we would end up turning it over to the police and medical examiner as a crime scene as somebody has died. This STEMI alert is if we see a STEMI on an EKG, we send it up to the hospital, we let them know we've got a STEMI, and then the hospital takes care of letting all the appropriate people know. So if somebody returns with a pulse, they essentially just became a high critical patient, right? They became an alive, unresponsive patient who has a high likelihood of going back into cardiac arrest. So save you the question, we're just going to treat them like a high priority patient, reassess their vital signs 24, as much as we can. If I ever got ROSC on somebody, I'd essentially have somebody designated to feel their carotid pulse. Feel it until we get to the hospital. If it stops, let me know again. These patients, if they get a ROSC, statistically are likely to go in and out of cardiac arrest until they get more stable care. We just start our assessment all over. Now, the last thing I wanted to talk about is because Vermont allows us to do termination of resuscitation or determine that we will not start CPR, it puts a big responsibility on us because now we have to communicate to the family. It's not as simple as saying, yep, we're down here, they're dead, right? Let's go get some Subway. No, most of the time they will have family on scene with them. And if you did cardiac arrest or you worked CPR protocol, they just watched you do a minimum of 20 minutes of very invasive and relatively traumatic actions on their family member. So if we determine that we are not going to continue efforts, that they are dead, we are also putting on the responsibility to ourselves of informing the family. Okay. So that's hard to do. And they could either range from being receptive and thankful to very angry and blaming you. And there's no way for us to determine what's going to happen. And there's no way for us to argue with them about their response. The best thing we can do is just tell them what happened and move from there. So here's what I like to say. So when we arrived, we discovered that your loved one was unconscious. They were not breathing and they did not have a pulse. We immediately began all efforts possible to try to resuscitate them. But after providing continuous CPR, breathing for them, administering medications, there was no change in their condition. And I have spoken to the doctors up at the hospital who have assured us that we have done everything that they would do. So I am sorry to inform you that your loved one is dead. Okay. It's hard to say. I've said it quite a few times. The hardest part is you have to say a form of the word dead. If you, as an EMT, say, I'm sorry, your loved one is in a better place. They have crossed the Rainbow Bridge. They have passed on. You are failing your patient's family. They need closure. You know what happened. They need to know what happened. Okay. So hopefully that won't have to be one of the biggest parts of your job, but it is part of the job. So if you guys have any questions, now would be the time.